annual PGCME. We are waiting the arrival of one of the examiners, which start in a very short while. In the meanwhile, let me congratulate the organizers for an excellent feast of scientific content yesterday. Also the excellent quiz program. I hope you all enjoyed yourself. Once again, phones on silent or on vibratory mode, please. The Department of General Surgery, MES, and the Malappuram Surgical Society under the banner of ASI Kerala chapter once again take pleasure in welcoming all of you to our second day of the annual chapter. We hope the PG students have been getting a full worth content of all the skills labs, hands-on work, and also the algorithms that have been put out just outside the hall. Kindly make sure you've taken pictures of all of them. Once again, on the second day, we have jam-packed sessions. We request all the speakers and presenters to kindly load in your presentations if you have not done so. We request you all to please stick to your stipulated time. Most of us will be traveling today. Also, we request the chairpersons to intervene whenever they feel it is right. Once again, let me just remind you, we'll be starting in a couple of minutes, just awaiting. Yes, I see Dayanand Babu sir there. Welcome, sir. It's my pleasure to invite all the examiners and the chairpersons now. We start the first session. The case presentation will be on oral malignancy. And may I invite the examiners, Dr. Sajid Kumar, Dr. Jimmy John, Dr. Ashok Nainan, and the esteemed chairperson, Dr. Dayanand Babu, onto the dais. Our case presentation will be handled by the Government Medical College, Thrissur, by Dr. Reddy Sandeep Reddy and Dr. Elvin Jo. Without much ado, we go on to our program now. We have a case presentation on oral malignancy, and over to the chairpersons now.
Good morning, everybody. I am Dr. Elvin Jo Kakasheri and my co-PG, Dr. Reddy Sandeep Reddy, junior residents in Thrissur Medical College. Here we are presenting a case of tongue ulcer.
Good morning, everyone. 59-year-old man who is daily wage worker hailing from Thrissur presented with chief complaints of ulcer, right lateral aspect of tongue for 2 months duration and pain for 1 month duration. History of presenting illness. Patient was apparently asymptomatic 2 months back when he noticed ulcer at right lateral aspect of tongue, which ulcer was insidious in onset, initially small in size and progressed to attain present size of a coin. Pain is sharp shooting type of pain which was intermittent in nature, aggravated on food intake or speech, relieved on rest. There is history of difficulty in speech and difficulty in eating food which worsened over last 1 month. Patient complains of inability to protect tongue and complains of excessive salivation and foul smelling breath. Patient had history of bleeding for ulcer, for which we visited local hospital. And patient had history of impinging sharp tooth near to ulcerated area. There is no history of discharge from the ulcer. There is history of loss of weight. He lost about 6 kgs in past 2 months. There is history of loss of multiple tooth due to trauma. There is no history of swelling elsewhere. No history of spicy food intake. No history of loss of appetite. No history of chronic cough, chest pain, hemoptysis, breathlessness, syncopal attacks, jaundice or bone pain. Past history, there is no history of similar complaints in the past, no comorbidities, no history of previous surgeries, no non-drug allergies, no history of COVID illness. He took single dose of COVID vaccine. Personal history. Patient is a chronic smoker for past 45 years, smoking 20 BDs per day. Pack years of 45 pack years. Is a chronic alcohol since 40 years. There is no history of any other substance abuse. Diet non-vegetarian, appetite normal, sleep is disturbed due to pain. Family history, no, there is no history of oral malignancies in the family. To summarize the history, patient is 49-year-old male, chronic smoker and alcohol, nil premorbid, presented with ulcer right lateral aspect of tongue and shooting type of pain with positive history of difficulty in speech, eating food, difficulty to protrude tongue, excessive salivation, foul smelling breath, bleeding from ulcer, sharp tooth and loss of weight.
General examination. Patient is conscious, cooperative, oriented to time, place and person. ECG score of 2, moderately built and nourished, no pallor, no tic-tric, no cyanosis, no generalized lymphadenopathy, no pedal edema. Patient is febrile, pulse rate of 82 per minute, BP 110/80. Inspection. Patient examined in daylight with proper exposure and with consent taken, in sitting position, mouth opening is adequate, poor oral hygiene, lips pigmentation present, no ulcer or no growth, commissure, no angular cheilitis, teeth, nicotine stain, dental caries present, crowded teeth with loss of multiple tooths. Tongue, an ulcerated area measuring 2 cm anteroposteriorly and 2 cm transverse is visible on the right lateral border of tongue, which extends 3 cm from tip of tongue, 1.5 cm from midline, 1.5 cm from circumvalent papillae, involving gingivolingual sulcus and is 1 cm from alveolar margin. Floor of mouth not visualized on right side. Visualized portion of floor of mouth on left side is normal. Patient unable to protrude his tongue. Palate, no ulcer, swelling or perforation. Retromolar trigone is free and normal on both sides. Buccal mucosa, no leukoplakia, no pigmentation, and appears smooth and shiny. Gums normal. Coming to palpation, tongue, tenderness present over ulcerated area, no focal rise of temperature, and ulcero-indurated growth of measuring 5 cross 2.5 cm located on right lateral border of tongue, which is hard in consistency and bleeds on touch. Which extends anteriorly 1 cm from tip of tongue, 1 cm from midline, posteriorly 1 cm from circumvalent papillae, laterally involving gingivolingual sulcus and 1 cm from alveolar margin. Induration extending up to floor of mouth and is 0.5 cm from frenulum. Rest of subsets normal. By digital examination normal. On neck examination there is 1.1 cm non-tender hard mobile lymph node, not in level 1B. Systemic examination. Respiratory system bilateral air entry equal, normal vesicular blood sounds present. Cardiovascular system S1 S1 head, no murmur. Central neural system, higher mental function normal and no focal neurological deficit. Skeletal system normal. A 15A, coming to summary, 59-year-old chronic smoker, chronic alcoholic with 5 into 2.5 cm ulcer-indurated area over his right lateral border of tongue with history of pain, difficulty in speech, difficulty in eating food, inability to protrude his tongue, halitosis with a palpable level 1B lymph node and induration at the floor of mouth. With this summary, probably the professional diagnosis is clinically T4A, N1, M0, stage 4A.
Can you just show the clinical photo? Clinical photo.
Patient was
You don't have clinical photo? Because we wanted to see the clinical photo. Right. You said that, how many pack years you said?
45, sir.
What is a pack year?
Pack years is number of packs smoked per day into
Number
total
of?
number of packs of cigarettes smoked per day. Total
Number of packs of cigarettes of how many number?
20 cigarettes per day
20 cigarettes.
in one pack.
So how many he is smoking?
He smoked up to 20 cigarettes per day almost. Two packs of BDs, sir, actually. So one pack contained 10 BDs. So two packs he smoked.
So 45 years.
45 years, yes.
Alcoholism?
40 years, sir.
How much?
375 ml of brandy he used to take
Every day?
every day.
Okay. And you said inability to protrude. What is it called?
Ankylosing glossia, unable to protrude tongue.
Ankylosing. It is there.
Yes, sir, is there.
Right. And then you said it is induration is going up to the floor.
Floor of mouth, yes.
But I want to know the level of induration to the contralateral side.
No, sir. No,
Whether
sir.
the
There
induration is
not crossing midline.
not crossing. Sure.
Sure, sir.
That is the most important thing. The floor of the mouth is involved or not?
Floor of mouth is involved on ipsilateral side, not crossing frenulum.
Same side, it is involved or only induration? You said induration.
It's involved, sir. It's involved.
Growth is involved.
Involved.
Then you said about gingivolingual sulcus.
Sulcus, yes, sir.
Normal or
Gingivolingual sulcus is involved, sir.
involved? Which part of the gingivolingual sulcus?
From first
Because
premolar,
it will extend posteriorly also.
yes, involving first premolar and molars, first molar.
That area. So it is extending posteriorly up to circumvallate.
Yes, sir. Just 1 centimeter from circumvallate.
Okay, okay. Then how can you say that he has lost 6 kg and then moderately built and nourished?
Actually, he was heavy initially. He lost now 6 kgs.
Yeah.
He is almost 70 kgs initially. He lost almost 6 kgs. He is now
How can
64.
you say that he is moderately built and nourished? And you said he has got sharp tooth.
Yes, sir. There is history of sharp tooth.
How is dentition normal or
No,
any
sir,
missing?
there is first premolar and second molar. First molar is missing, sir.
Missing.
Because of trauma. He had 5 years back. He had history of trauma during which he lost.
So first molar, which side is missing?
Right side, same side.
Same side.
Same side.
Any loose tooth?
Loose tooth passage is not there, sir. But there is crowded teeth. First, like lower incisors or canines are crowded.
And you mentioned about bidigital palpation.
Yes, sir.
Of what?
Supraomoid muscle, supraomoid muscles, like floor of mouth. Right,
Did
left
you
side.
Any bidigital palpation at the
Of
mandible?
mandible also we did, both.
Done or not?
Done, sir.
You didn't mention. What is the finding? Why you look for bidigital palpation? of
To check for any involvement of mandible.
what type of involvement?
There may be thickness of mandible or erosions,
Or one more thing, fracture also.
fracture of mandible.
So nothing is there.
Nothing is this.
Right. One more thing, any hypoglossal nerve palsy?
No, sir. Actually, he is unable to protrude tongue, but there is no deviation of tongue.
Nothing.
Nothing. Sir.
Inability. And you said there is no trismus. What is trismus?
Trismus is difficulty in opening mouth. Actual definition is like there is grading for trismus, sir.
Yeah, what is the grading?
Inter-incisional distance greater than 35 mm is grade 1, 25 to 35 mm is grade 2, 15 to 25 mm is grade 3, 5 to 15 is grade 4, less than 5 mm or unable to open tongue is grade
What are the causes for trismus?
like infiltration of masticator muscles of mastication,
Involvement of
Oh.
retromolar trigon.
involvement of retromolar trigon,
What are the other causes for trismus?
hypocalcemia,
Hypocalcemia,
calcemia,
calcemia,
tetanus,
tetanic,
tetanus.
Tetany.
Oh, what is it called?
tetany,
Huh?
tetanic spasm.
In which condition you get in tetanus?
hypocalcemic.
Rhizus sardonicus part. Okay, other causes, our surgical conditions. I want to know the surgical conditions. Trismus. Any parotid condition?
Parotitis.
Parotitis, parotid abscess.
Parotid abscess.
What about any dental condition?
Dislocation of
Ameloblastoma.
Dental abscess.
Abscess.
Any other condition? What is quinsy? I think quinsy.
Quincy is abscess in
think
Tonsillar abscess.
you should know the
Bed of
conditions producing trismus. Any submucous fibrosis? You never mentioned.
There is no submucous.
Did you examine for
Yes,
that?
yes, sir.
Any leukoplakia?
No, sir, no leukoplakia,
Erythroplakia.
no erythroplakia, no
What is
leukoplakia.
leukoplakia?
Leukoplakia is a clinical condition. It is characterized by white plaque which cannot be distinguished into any other condition pathologically or clinically.
Right.
You said that there is ankyloglossia. What is the reason for the ankyloglossia and what's the importance?
Infiltration of flora,
Infiltration of?
flora of mouth is
Infiltration of,
and pain and infiltration of flora of mouth, sir.
is the reason for the ankyloglossia here,
Yes, sir. You can-
For this patient.
for this patient? Is the importance of the assessment of ankyloglossia in a tongue lesion?
Sir, pardon.
Is the importance of assessing the ankyloglossia in a tongue lesion?
No, it is to look for the posterior
Look for the,
involvement of masticator space and posterior.
masticator phase is also related to ankyloglossia. Is it a mucosal lesion or something going deep? Is it a mucosal lesion or going deep? Is the lesion going deep or not?
No, sir, it's like up to flora of mouth it is infiltrating, sir.
No. What are the components of tongue? Is your condition is like tongue malignancy.
Yes, sir.
What are the components of tongue? What constitute the tongue?
Intrinsic muscles, extrinsic muscles.
How many muscles are there?
Intrinsic 4, extrinsic 4, sir.
Okay. So what is the importance of knowing these muscles and what is the importance of
Genioglossus can be infiltrated so that
the intrinsic muscles can be
Can be infiltrated.
infiltrated by the muscle, the tumor, and that's the reason why the
Ankyloglossia.
in your condition there is an ankyloglossia. Okay. And what is the importance of pain here?
pain due to infiltration of nerve, lingual nerve.
What are the different types of pain you may anticipate in such patients? Suppose the patient is saying that I do have. What are the types of pain? Isn't the pain in the tongue region alone or something somewhere else?
Types of pain. Infection can be pain.
No. You do have any variants of the type of pain there?
Like continuous intermittent shooting.
What are the nerves involved there? What are the nerves involved in that area?
Lingual nerve,
Okay.
Inferior alveolar.
inferior alveolar.
Okay, you can have mandibular
Mandibular,
pain, you can have mandibular
mandibular,
pain. Then, do you have earache in tongue
No, sir,
lesions?
no referral. We can have, but in this patient there is no.
What is the reason for that?
Because involvement of auriculotemporal nerve of mandible.
That's the reason. That is the one you have to answer. You are asking what are the type of pain. You have got a
Referred pain,
referred in the
pain,
ear. You can have pain in the mandible.
Mandible.
Because both of them here there. Okay.
You said that there was involvement of the gingival-labial,
Lingual cells.
huh?
Lingual cells.
gingival-lingual sulcus. Was there involvement of the bone also?
No, sir, no involvement of bones.
No involvement of the bone. You palpated it?
Yes, sir,
You
palpated.
can palpate. Okay. And what about the lymph node? What was the...
Level 1B lymph node is
Yeah, you said level 1B. What was the consistency and the size?
hard in consistency, about 1 into 1 centimeters.
1 into 1 centimeter. You feel that it is significant?
Significant.
But no. Did you look for any other pre-malignant lesions in the...
Yes, sir, those no leukopenia, erythroplakia, candidiasis.
which one? Candidiasis. Then what else? What are the other pre-malignant lesions that you look for? You said previously with submucosal fibrosis.
And we
Anything else?
Chronic verrucous proliferative leukopenia, hypertrophic leukoplakia,
Okay.
keratosis congenita.
Yeah. What is the percentage of malignancy occurring in one of these pre-malignant leukopenia?
4 to 10%.
4 to 10%. Over how many? How long? Over what duration? What is the risk?
10 years.
More
10
than 10 years.
More than
20
10
years.
years.
It will
20
be,
years.
20 years it is only around 4 to 5%. Okay.
Okay. Your actual size of the tumor is?
5 cross 2.5.
Inspection wise, you mentioned that it is 2 centimeters.
2 into 2 years.
So how much?
Ulcer, induration is
Because of the
extended.
induration, you are
extended.
accounting that as a 5 centimeter tumor. Okay. So it's a T4. B?
T4A, sir.
T4A. T4A. Okay, T4A lesion with an N1 lymph node.
N1.
How do you further evaluate the patient?
Evaluate,
Any differential diagnosis?
it's a no differential diagnosis.
No.
Carcinoma.
What are the other causes for ulcer tongue?
Dental ulcer, after ulcer, syphilitic, tuberculosis.
So why you are not having any other differential diagnosis? What are the specific reasons you have mentioned that these are your probabilities but not here?
Ulcer about 2 months, progressing in size.
What is the edge of the ulcer looking like?
Rolled out.
You never mentioned that. You just mentioned because
Bleeding on that.
the
Bleeding out.
typical description of a malignant ulcer you are not giving. You are just mentioning a big ulcer there. So, what will be the appearance of a malignant ulcer?
Punched out, rolled margins.
In other words, what are the types of growths of the tongue?
Ulcerative,
You mentioned ulcer. What are the other types?
proliferative growth,
Then? Have you heard of infiltrative?
infiltrative lesion.
What is verrucous?
Varicose carcinoma is low-grade squamous cell carcinoma.
Not grading. What will be the appearance?
It's warty, exophytic lesion.
Exophytic. So it may be exophytic, may be ulcerative,
Ulcerative,
may be infiltrative.
infiltrative.
So different types are there. So what type of, so other causes, you never mentioned the edge. Edge is very important. And the lymph node is mobile or fixed?
Mobiles. No, it's
Level on, you said submandibular.
submandibular.
Submandibular. Okay, how do we manage?
We'll first investigate the patients. We can radiologize.
Always you should have 2-3 diagnoses. You should know the causes for ulcer tongue. Otherwise, you don't reach anywhere. Maybe typical malignancy, but you should know the causes for syphilitic
Syphilitic,
ulcer,
tuberculous, dental, aphthous ulcer.
so many rhomboid ulcer, median rhomboid.
Remember,
So many things are there. You should know all those things. Okay, in the exam. Okay, go ahead. How do you proceed?
We'll investigate the patient, radiological investigation, ultrasound. MRI is preferable than CT.
First you say radio.
Radiological imaging.
What imaging?
MRI is ideal, sir, but we can, depending on the center and affordability, we can go for CT also, contrast enhanced helical CT or
What is the purpose of MRI?
MRI to look for soft tissue infiltration, depth of invasion and soft tissue infiltration. It is like more sensitive and specific than CT for this. But for hard structures like bone, CT is preferable. And MRI have no degradation due to this dental restoration materials. CT is
Depth of invasion.
depth of invasion. Actually, it is from length of tumor from
It is
base.
pathological or clinical or radiological.
Depth of invasion more reliable is pathological, sir, post-op, pathological, but we can do radiological also, but it's not reliable. It depends on technician, everything, but pathological is standard for depth of invasions.
So MRI is your investigation of choice.
Yes, sir.
But then you said CT also.
CT depends on the center, sir. Actually, this some centers may not have a MRI and affordability of the patient if he is from private setup, everything. And claustrophobic patients, we can go for CT.
How does an MRI score over CT? How does an MRI score over CT? What is the advantage of doing an
Advantage is soft tissue differentiation and infiltration is better on MRI.
What infiltration is better? What infiltration is better?
Soft tissue, muscles,
Huh?
muscle
Muscle infiltration. Anything else? You were specifically looking for in a
lymphovascular, vascular, neural,
perineural
perineal invasion.
marrow infiltration.
Marrow.
These are things that you will, have a better delineation in MRI as compared to CT. Bony infiltration, you will probably do with CT.
CT is investigation.
What about the lymph nodes?
Actually, lymph nodes both are equally safe, CT and MRI.
Yeah.
So after your imaging, how do you proceed?
Proceed with incision biopsy, preferably from the more suspicious area, avoiding center because more of necrosis will be there. We can take edge biopsy. And usually,
What type of edge biopsy? Edge biopsy, you
with
said.
normal surrounding healthy tissue
What is
also.
it called?
Wedge,
It will be
wedge,
wedge.
wedge,
Oh, okay.
wedge biopsy.
So you take biopsy and then what type of malignancy you get in tongue?
Most commonly it is squamous cell carcinoma, more than 90%.
Any other malignancy possible?
Mucoepithelioid, basiloid,
Basaloid, mucoepithelioid.
papillary.
If it is already minor salivary glands, it is adenocarcinoma.
Minor salivary gland. Yes, then?
Varicose
Sarcoma
is-
possible?
Rare actually. Tongue muscles are rare, very rare.
What are the causes of macroglossia? Macroglossia.
Macro tumors.
Can you have a
Vitamin
lesion?
B12.
No. Tumor. You can have metabolic conditions producing macroglossia, but regarding the tumor, it sometimes
Adenocarcinoma.
a soft tissue benign lesion can
Soft.
happen, myoblastoma,
Myeloma.
like lesions. That's why. So when Sari is asking what are the other causes of tumors there is one benign or malignant tumor there, other than the surface tumor. That's but not from the epithelium arising from that. So that has to be also.
Amyloid.
Okay, so you have done a wedge biopsy, and what about the lymph node?
Lymph node we can take FNAC.
You have done an
FNAC, ultrasound guided blind.
You do an ultrasound. What's the advantage of ultrasound? Because a palpable lymph node there. Still, why do you want to have an ultrasound if it is available?
We can also assess lymph node when we are doing ultrasound, both investigative and therapeutic. As-
Surrounding structures will be more. To avoid vascular or vascular injury during.
In the submandibular region.
No, sir. No, not vascular injury. We'll just
Purpose is to have a guided.
a guided FNAC.
Guided FNAC.
So what are the things usually in the lymph nodes when you have a suspicion
Ashes,
of
we'll look
malignancy?
for size of the lesion, necrosis, any loss of hilum, shape,
Rounded shape.
rounded shape is
And you can have a
except one.
representative area. You can take a representative area for your sampling. That's importance of a guided thing if it is available. That's most of the time you may do that without ultrasound also. So both are done. So you have got a report of a moderately differentiated squamous cell carcinoma with a malignant cells in the node. How do you proceed?
Would you like any other investigation before proceeding?
Blood investigation for
No,
anesthesia.
any other investigation would you like to have before you proceed to treating this patient? You said there is loss of teeth,
Yes.
isn't it? There is loss of teeth. I said, I think you said.
Orthopantomogram.
Orthopantomogram. It may guide you regarding
Regarding
dental
dental
evaluation,
evaluation.
treatment. Would you do a PET scan?
PET CT, usually we won't go for oral cavity malignancies unless it is a recurrent lesion or we are lymph node of unknown primary. We don't go unless it's recurrence or lymph node palpable of unknown primary origin.
Any other advantage of doing a PET scan apart from unknown primary and recurrent lesion?
Synchronous or metachronous lesions.
Lesions in the aerodigestive. You want to evaluate the entire aerodigestive tract for any
Synchronous
synchronous
or
lesions.
meta.
Will you take X-ray chest or CT? If so, what is the reason?
CT chest.
X-ray or CT?
CT chest is
For what?
to look for any synchronous or metachronous lesion also we can go for.
Where?
Lungs,
So you have to always evaluate the upper aerodigestive tract because the carcinogen is safe. So you have to 40-45 years long duration. You have to always do. And how do you treat? What type of?
Right.
You advise surgery or
Surgery is treatment.
radiotherapy or both? How do you
We'll
manage?
treat with primary surgery, then adjuvant radiotherapy. Surgery is like wide excision with 1.5 centimeter gross margin, so that we can get at least 1 centimeter
So how
histological.
wide do you excise? You said wide
Wide
excision.
excision.
How wide?
With
1.5 centimeter gross margin, so that we can have at least 1 centimeter
So
histological margin.
finally, what will be the procedure?
Wide excision.
In this case,
This
your
case.
wide excision
Wide
will
excision with
become
lesion,
what?
floor of,
What is the terminology you may be modified after your wide excision? You might have been removed
Hemigloss-
so much of the tissue.
hemiglossectomy.
Hemigloss.
Hemiglossectomy,
What is hemiglossectomy?
removing one half of tongue and 2/3.
When you remove less than 50%. So is it enough for this patient,
Yes. With
Enough.
floor of mouth, yes.
It is not crossing, but hemi is possible according
Yes,
to
sir.
you.
Yes, sir. Hemi is
So-
possible.
So question is wide or hemiglossectomy in this case?
Hemiglossectomy.
Eh?
Hemiglossectomy.
So you should mention hemiglossectomy.
Hemiglossectomy.
Alone or any other combined with
With excision of floor of mouth,
excision of floor of the mouth.
infiltrated part, and hemimandibulectomy. Or actually, in our center, we usually go for hemimandibulectomy, sir.
Why? Why hemimandibulectomy?
We can do marginal mandibulectomy.
This is not involving the
Mandible.
So
Like
why?
we go. Sir.
Eh?
Marginal mandibulectomy, so that there is continuity
Why
of the bone.
marginal mandibulectomy? It is
Marginal-
not abatic.
Not a bit.
So
But
why?
less than 1 centimeter from alveolar margin also, we can go for marginal mandibulectomy.
Okay, marginal mandibulectomy and what else?
Modify radical neck dissection on right ipsilateral side.
MRND?
MRND.
Why MRND? Why not supraomohyoid?
Because therapeutic neck will
Notice
What is the
already,
reason?
already one node is ignored.
not therapeutic. We are going for therapeutic neck dissection. Already one node is
What about the contralateral side?
contralateral side.
Because tongue is one organ, what is the lymphatic drainage?
Tongue, sir. Tip of tongue to submental, lateral border to submandibular and level 2 lymph nodes. Upper cervical, deep upper cervical.
Deep means vague. What
Level,
about
upper jugular, upper jugular.
It will go up to
Jugular,
jugular.
omohyoid.
Isn't it? So the contralateral side also, how do you manage?
Usually we
Contralateral side is N0.
M0s. We can match, no, sentinel lymph node.
Apart from the surgery, do you have any other options in a tongue malignancy?
No,
Not in
in-
this condition.
For this condition.
No, not in your case.
No.
What are the other
In
options?
stage 1 year, we can, stage 1 we can go for radiotherapy, sir, primary radiotherapy.
What are the different options of radiotherapy? What are different types of radiotherapy you may have?
External beam, brachytherapy,
What brachytherapy are you using with what? What is the material used for brachytherapy? Any wire? Radioactive wire? Iridium.
iridium.
Okay, that is the one, that is a brachytherapy treatment. So what are the contraindications? Suppose it's a T1 lesion, but still we may opt for surgery.
Pregnant women,
Then any location of the tumor, any location of the tumor have any specificity to not being selecting for radiotherapy, even if it is an early one?
Posteriorly located, difficult to.
Tip of the
tip of tongue.
tip of the tongue. Tip of the tongue usually you may opt for a surgery rather than radiotherapy. That's all. Any chemotherapy agents?
Is a cisplatin, 5-fluorouracil. Recently, there are PD-1 inhibitors which are being evaluated, but they are not into practice yet now. They are in great trials only. But drug of choice is gold standard is cisplatin, sir, which we give 100 mg per square meter surface area over like 3 weekly regimens.
See, what is the age of this patient you said? 70?
59.
59. So even if it is 59, you'll have to, before you plan your surgical management or any management, you'll have to
Cardiovascular,
assess the,
cardiovascular,
you'll have
cardiovascular
to assess the
evaluation.
patient because this is a major surgery,
Is it?
isn't it?
Cardiovascular evaluation.
Yeah, you have to assess the options available, assess the fitness of the patient before you plan your surgery for surgical management.
Yes.
What are the reconstruction options that you have?
Ideally, we can go for PMMC, in Innova Center, usually you go for PMMC flaps, sir. But free flap in higher center, they can use free flaps. If it is bulk, we can go for anterolateral thigh or rectus abdominis. If it is small defect, we can go for radial forearm flaps, microvascular flap.
Free flap.
Free flap.
Isn't it? Which is a preferable,
Free flap is,
isn't it? Why?
Yes.
Why is it preferable?
Rehabilitation.
Why is a
But-
free flap preferable? Radial.
rehabilitation.
Huh? Beg your pardon?
Better.
Better cosmos is,
Oh,
functional outcome is,
Functional movement.
Tongue
movement.
movement.
Functional outcome is better.
Functional
Outcome is better with free flaps.
better, more reliable
More reliable and-
flap as far as the vascularity concerned, isn't it? And anyway, you're doing a neck dissection, so
We
your
can
recipient vessels are,
anastomose
yeah,
facial
anastomose
artery.
is not be.
Mm.
What is the advantage of a radial free flap? Advantages? Are there any other advantages? It has got a long pedicle. Long pedicle.
Pedicle length is
Yeah,
10 to
and
20.
the size of the vessel is also adequate
Right.
for your anastomosis, isn't it? Okay. Yeah, I think we are running out of time. I request Dr. Dayananda Babu to.
I think oral malignancy is very important for your examination. You should know the not only tongue, then the gingivo, labial. What is Indian oral cancer? Last question. What is Indian oral cancer?
Gingivobuccal sulcus,
Sulcus. That's the commonest
commonest in India.
India because of the
PID.
PID. So you should know the constituents, everything. So I think,
Slimes.
yeah, you should be thorough with oral malignancy. You have done well. Okay. Thank you.
Thank you.
Thank you so much. May I invite Dr. Jimmy John to kindly join the chairpersons? Dr. Jimmy John, kindly join the chairpersons, please. Our topic presentation now by Dr. Sri Kumar Atulya, please.
Good morning, everybody. Thank you for having me here. The topic for me is management of an N0 neck. Cervical lymph node metastasis probably forms one of the most important prognostic factors in oral cavity squamous cell carcinoma. Once cervical lymph node metastasis occurs, the prognosis drops by 50%. There is an increased chance of distant metastasis as well when cervical lymph node metastasis occur. Hence, the treatment or the optimal treatment of the neck is very, very important in a head and neck squamous cell carcinoma. As shown here, if it's a localized disease, it's approximately 80% 5-year. If it goes to the node, it is 40%, and if it is systemic, it is 20%. So you could very well appreciate the dismal prognosis of a cervical lymph node metastasis. So what are the challenges that we have? How do we find who are the patients who would have occult lymph node metastasis? That is the challenge. One, if we have a challenge, we have a rule immediately popping up. Rule has come that if the percentage of occult metastasis is more than 20%, you have to treat the neck. So what is this N0? Is clinical examination sufficient for N0? Not at all, because up to 50 or 60 to 70% you'll be able to pick up. In a short neck, in an obese neck, in a muscular neck, in a post-fatty neck, clinical examination is fallacious. So what do? Workup from ultrasound to PET-CT has been recommended. Of course, PET-CT is the best with an excellent sensitivity and specificity, but again, a very costly investigation. So on a practical note, I would suggest that an ultrasound would suffice because it has got a reasonable sensitivity and specificity. Factors affecting the 20% rule: 1 is site of the tumor, 2 is size of the tumor, 3 is tumor thickness, and 4 is histological parameters. Site, favorable, unfavorable, probably among the various sites in the oral cavity, tongue and floral mouth are the only 2 unfavorable sites. And in floor of the mouth, it is more than 25% chance of occult metastasis, whereas in tongue, it is approximately 60% or more chance of occult metastasis. Size self-explanatory. As the T stage would go up, so would the chance of occult lymph node metastasis going up. In T3 and T4 lesions, it is close to 50 to 60%, whereas in T1 and T2 is around 15%. Tumor thickness probably the most important prognostic factor, and earlier it was believed that it was 4 mm thickness, and now probably it has even come down to 3 mm thickness, and this is a radiological sign purely detected on a well-conducted MRI. Due to time constraints, I am not going into the sequences of the MRI, but a well-conducted MRI would really tell you what is the exact tumor thickness. This is probably the same data. And histological parameters, grade of the tumor, presence of perineural invasion, presence of lymphovascular invasion. These are the parameters on which you depend whether you to go ahead with the neck. So what are the questions that you would answer in N0 neck? Is there a need to treat an N0 neck? And if so, who are the patients that you would treat? And if so, how you would treat? And fourth is this intervention going to be beneficial to your patient? These are the 4 questions that you need to answer. The various considerations, like your treatment should not be more morbid than the disease. So you don't want to treat the patient unnecessarily. And is there a need of entering the neck for reconstruction? If so, it may be better that you do the neck. And will my patient be lost to follow-up? That's a question of concern to me. And what is the modality of evaluation for a follow-up? Do I have a foolproof modality for evaluation for a follow-up? And how am I going to treat the primary tumor? These would be my considerations when I think about treatment of an N0 neck. Treatment options: 1 is close observation, 2 is elective neck dissection, 3 is elective neck irradiation, and 4 is sentinel lymph node biopsy. Observation: very small size tumors, superficial tumors, good histology tumors, favorable site, and last but not the least, I would repeat, a compliant patient is absolutely necessary for observation, because it's a very, very risky proposition to observe a patient if you don't have a compliant patient. And when there are 2 options, obviously there will be proponents and opponents. The proponents say that if it is not observed properly, they don't progress in a very orderly fashion from N0 to N1, N2. So that is one thing, and in 75% of people in the observation arm, they come with either an N1 disease or with extracorporeal extension. And the salvage rate, if a regional recurrence occurs, is in the tune of around 50 to 60%. Again, this is the debate. Debate keeps continuing. People say there are people voting or vouching for an elective neck dissection. On the other side, people vouching for a. But again, grossly, it all decides that what is the percentage of occult metastasis. Is my treatment going to be beneficial to my patient or not? Again, it is the decreased relapse rate, improved overall survival, improved disease-free survival for the people who say that therapeutic elective lymph node dissection, therapeutic dissection says that it is not too much different. So again, the debate keeps continuing. This is one of the very important papers by Dr. Anil de Cruz, in which this is a randomized controlled trial in which he has given data about an overall survival as well as a disease-free survival. Overall survival for an elective lymph node dissection is around 80%, whereas it's 67.5% for a therapeutic neck dissection, and disease-free survival also is similarly 70% for a elective and 49.5% for a therapeutic neck dissection. This is again extrapolation of some data from the same paper. 29.8% of people come with pathologically positive node. So we are going to miss around 30% of people if you keep the person under observation. Finally, NCCN has said that if it is lip for a T1 and T2, you could choose observation. If it is T3 or T4, better to do an elective neck dissection, but observation also is an option for lip alone. For other sides, T1 and T2, as I said, observation of course is mentioned, but is not a very good recommendation. Elective neck node dissection and your elective neck node irradiation and sentinel lymph node biopsy, whereas if it is a T3 or a T4 lesion, always elective lymph node dissection is a must. And these are some of the randomized controlled trials which have shown that the neck recurrence rate is obviously significantly higher if you wait for an elective lymph node dissection rather than going for a. And the conclusion from all this is elective lymph node dissection has a better overall survival and a disease-free survival in a clinically node-negative squamous cell carcinoma, and depth of invasion is the best prognostic indicator to decide. Now coming to elective node dissection versus elective node irradiation. There are no prospective data, only retrospective data says almost they are equal, but it again depends on what is going to be your modality of treatment for the primary. If you are going to opt radiation as the treatment for the primary, probably radiation, elective neck radiation would be a reasonable option. Otherwise, no. Sentinel lymph node biopsy, node to which the disease spreads first or the first equivalent node, and if you get a positive sentinel node, probably you are justified in doing a sentinel, doing a therapeutic lymph node dissection or an elective lymph node dissection. And sentinel lymph node biopsy is a valid option for squamous cell carcinoma of the oral cavity. It needs expertise, and patients undergoing sentinel lymph node biopsy and being left alone needs a very close follow-up. And the sentinel lymph node which is being retrieved should be meticulously assessed, including immunohistochemistry, to look for isolated tumor cells and micrometastasis before taking a final decision to leave the patient alone. It is recommended only in T1 and T2 lesions to be done in centers with good expertise. Flow of the mouth not routinely recommended because of less sensitivity. Alveolus not recommended because injection is difficult. There is no particular agent and the pooled estimate of sensitivity is around 93%. There are two randomized controlled trials which has come. One is the Dutch trial which shows that sentinel lymph node biopsy is a viable option, and second one is a trial from Japan which again shows that sentinel lymph node biopsy is a viable option in T1 and T2 squamous cell carcinoma of the oral cavity. My take-home message would be elective lymph node dissection should be the standard of care for early stage oral node-negative oral cancers. One death is prevented for every 8 patients treated with elective neck dissection, and one recurrence is prevented for every 4 patients treated with elective lymph node dissection. Sentinel lymph node biopsy can be attempted in select patients in centers with expertise. Observation is not a recommended option. Thank you very much.
Thank you. It was a very nice talk. So, the previous case also we were discussing the contralateral side. I was asking N0, we should treat that N0 neck, especially it is tongue.
So,
Yeah.
the recommendation is if there is any lesion which is reaching the midline, or if it is a midline lesion, or if it is a structure where there's a lot of crossover of the lymphatics, it may be better that you address the opposite side also, and it is a selective dissection at the opposite side. And it is not an MRND of the opposite side. Selective dissection for tongue, I mean a supraomohyoid dissection or an extended supraomohyoid dissection.
That was my question. Contralateral side also one should treat
Yes.
by suprahomohyoid.
And this lesion was almost reaching the midline. So probably it was justified to treat the opposite side as well.
That was my.
Yeah, that is what I also wanted to ask, whether you would opt for a elective suprahumoid.
Yeah, again depends, as I said, where the lesion is.
Yeah, this particular one.
Yeah, I think I
They
would do.
presented it as 1 centimeter away from the midline.
I think I would do. And MRI is the recommended investigation of choice. And in MRI, you mainly use 5 sequences. One is T1 plane, 2 is T2 plane, 3 is T2 with fat suppression, which is otherwise called a STIR, and 4 is T1 with fat suppression, and 5 is T1 with contrast. Because in India, we don't have a T2 contrast, and the T1 contrast uses gadolinium. These are the 5 sequences which we normally use in an MRI in an oral cavity.
How often in your practice do you do sentinel lymph node?
For oral cavity, I have not done at all.
You don't use ICG?
No, of course, we don't have that in our center, that's one thing. And otherwise also, I have not used that for oral cavity.
Okay. And you said the ultrasound is adequate for evaluation, but
Yeah.
Is that your practice? I thought
But
it would be.
no, since we do an MRI,
that-
yeah, it covers. But I was saying that if suppose you're not doing an MRI, ultrasound would suffice. Even though PET CT has a very high sensitivity specificity, ultrasound has a pretty much sensitivity and specificity. So ultrasound would also suffice.
PET, you are routinely suggesting or
No,
mention PET?
no, sir.
To rule out lesions in other sites.
I don't think PET is an upfront investigation for an oral cavity squamous cell carcinoma. Esophageal malignancy, lymphoma, myeloma, and one more thing, lung malignancy. These are the 4 malignancies which I think should go for an upfront PET.
Any questions? Yeah.
That is what sir was asking. It all depends what is the site of the primary, whether it has crossed the midline or whether it is approaching the midline. My choice of the opposite side would depend on that. No.
No, you was
That-
mentioning that it is reaching up to the midline.
Yeah, in this case, yes. A dead lateral lesion pulvifer, I don't think we should be addressing the contralateral side. Any, Madhu?
As you rightly said, sir, I don't think we do have practice of routinely addressing the contralateral neck unless, as you said, you have a lesion which is approaching the midline or you have a heavy nodal disease in midline nodes. Then you may cross out others. Otherwise, routinely for a lateralization, no. Because anyway, most of these patients would go for a post-op RT.
Yes.
So that would cover to some extent the occult nodal metastasis that may be there on the opposite side also.
You are doing any sentinel node in center?
No, sir, just for sake of doing it, 1 or 2, I just asking, I don't know if our resident who just passed out asked it. So he was saying that I don't look into head and neck OTs these days, but I'm in another OT. So just for sake of doing it, few cases we are done, but not as a routine, we are not doing it. But as you said, ultrasound is a very sensitive investigation for picking up nodes which are not clinically picked up. And you have any doubt, you can add an FNAC to that and confirm whether it's a positive.
Maybe Tata is doing or?
No, PET scan should, as you rightly said, PET scan should not be used as a primary
No,
modality.
not
of-
PET,
FLND.
Yes, sir,
sentinel.
I don't know
many centers are doing that.
actually of any center which really does sentinel, but
The paper is Anil de Cruz paper.
no, Anil de Cruz paper വേറെ ആൾക്കാരെ elective lymph node dissection. That one is a Dutch and a Japanese study.
Okay.
Anil de Cruz's study was elective versus therapeutic dissection.
The sentinel node has caught up in your breast cancer, endometrial cancer, so many other areas, but head and neck it has not evolved the way it has evolved in other sites.
Any other question? There are no more questions. We will wind up. Thank you. It was an excellent.
Thank you.
Thank you, Dr. Sri Gurvan Pillai, and thank you to the chairpersons and the examiners. We have a couple of certificates to hand out. May I request the chairpersons to kindly do the honors? Dr. Dayanand Babu, please. Request all the others to kindly join in. Thank you very much, sir. The e-poster competitions will be held at 12 p.m. at the conference hall on the ground floor. The shortlisted PGs, please be there on time. Once again, the e-poster competition will be held at 12 p.m. in the conference hall on the ground floor. List of students selected for lunch with the teachers. It will be held during the lunch session today. It is on display at the back of the hall. Lunch with the teachers will be held at the terrace adjacent to the hall. Kindly make note, the list of the students will be displayed at the back of the hall. Lunch with the teachers. Kindly make sure your names are present there. We move on to a special round now, the ward rounds, which will be live telecast. Dr. Santosh John Abraham is there with our PGs. We have the ward rounds, which will be live telecast in the hall right now. A special session, the ward rounds, which will be telecast live here in the hall.
Good morning to all of you. Thank you, Team Perindalmanna, for initiating this very novel idea of having a ward rounds. It's a 1 hour program. There are 2 cases that have been devoted. One is a pre-op case where some issues in pre-op settings will be discussed, and the second one is a post-op. We are initially taking up with the post-op case for half an hour, and a team from Trivandrum Medical College is going to be team answering the questions. If there are any questions which are not answered by them, it will be passed to the next team, which is Medical College Calicut. I would request you to introduce yourself.
Good morning, respected colleagues and faculty members. I am Dr. Abraham I. Thomas. I am from Trivandrum Medical College. I am currently in my second year of training in general surgery.
I am Adira Aravind from Government Medical College Trivandrum, second year junior resident in general surgery.
And you? Okay, so those are the teams. The first team will be answering these questions. So you have been given the case scenario, isn't it?
Yes, sir.
So you can just tell what was the initial surgery the patient has undergone, just in few words.
So the patient had presented with complaints of persistent abdominal pain, which was evaluated and was diagnosed to be adenomyosis, for which he underwent a total abdominal hysterectomy. That was on the 16th of this month. Post-operatively, she was doing well, and except for the post-operative pain, and hence she was discharged on the 5th post-operative day. But on the 6th day, she came back with complaints of abdominal pain and abdominal distension.
The very next day after discharge?
Yes, sir. The very next day after discharge, she came back.
What was the complaint?
With persistent abdominal pain, abdominal distension, and loose stools. Multiple episodes of loose stools.
Okay. So till 5th post-operative day, she was absolutely fine. The catheter was removed and patient was sent home.
Yes, sir.
So with this picture, when they come, that is loose stool, abdominal pain, was there any distension of abdomen?
Yes, sir. There was distension when she came back.
Distension. Was she having any fever at that point of time?
The patient was having fever when she was at home, but at the time of presentation, she was apoptotic.
So with this history, if they come to the casualty or the OPD, what would be the things which go through your mind?
So first of all, since she is a post-operative case, presenting with multiple episodes of loose stools, we will be thinking more in line of a pelvic abscess, which is causing the loose stools, especially common in gynecology and pelvic surgeries.
Elective surgery. It is an elective surgery, isn't it?
Yes, sir.
If there is no loose stools, what would have been your thought process?
If there was no,
Is there any question from there? No, okay. If there was no loose stool, what would have been your clinical thought process?
With abdominal pain, distension, it could have been paralytic, post-op paralytic ILS, which will usually
Will that create fever? Paralytic ileus?
no, sir. There will be constipation with abdominal distension.
In paralytic ileus is, a patient who has had 5 days of smooth hospital recovery. Do you think that the paralytic ileus would be entertained at that point of time? Let's imagine the patient has got pain and fever. What all things will go through your mind post-op 6th day?
Cervical site infections.
Cervical site infection, good.
Sir, any UTI?
UTI, particularly when the gynae patients, they have a catheterization, invariably all hysterectomies, UTI.
Sir, and sometimes due to prolonged immobilization, DVT can also.
Generally, the fever is not the predominant symptom in a DVT. Or if there is a long central lines, you have to look at the capital, central line related infection. So these are the usual causes. Now this patient had distension of abdomen. So that brings in yet another group of conditions, isn't it? What are those conditions which you get with distension of the abdomen?
Any deep-seated infection in the
Okay,
cavity.
so patient with fever, abdominal distension, post-op, you are thinking into your thought process is right in pelvic abscess. Excellent. So what do you plan to do for this patient?
So first of all, we have to confirm our diagnosis of pelvic abscess.
Do you like to examine? You have given me only a history.
Yes, sir.
Yeah.
First, we will like to examine the abdomen of the patient, confirm whether she is having any signs of peritonitis as such.
What about the wound? To start with, you look at the wound. Is there a discharge from the wound? Is it looking angry? Is it having any discharge? Is it yielding pus? Isn't it?
Yes.
Look at the temperature of the patient. Is she febrile? Don't jump into abdomen just because she had a laparotomy, right? Don't jump into abdomen. See whether she is breathing normally. Why do you want to look at the breathing of the patient with fever?
Might be tachypneic
Due
to the fever and because of the systemic toxicity.
So she is a candidate for a sepsis.
Yes, sir.
So you can look at the temperature, you can look at the breathing pattern, whether she looks sick or not.
Yes.
Isn't it? Okay, fine. So you come to the abdomen.
So in the abdomen, we generally see if the abdomen is soft and
You see the abdomen, whether there is a distension or not first.
yes.
Isn't it? Yeah. And then heartbeat. What you are trying to elicit?
Guarding or
Why do you think that on the 6th day somebody should have a guarding?
so if there is any underlying collection, we might have guarding over that set or that area.
Okay.
And if there is, we also have to look for any induration more the abdominal wall that there is.
That first of all, we have seen whether the scar is good, whether the wound is good.
Yes.
Okay, fine.
Any local rise in temperature.
Local rise in temperature is a parietal phenomenon, isn't it? Parietal phenomenon. You don't get local rise in temperature in a pelvic abscess,
Yes.
right? So what else will be looking for? Or what are the other things? Pelvic abscess, I agree. Abscess somewhere. Fine.
So-
Pelvic abscess being common, I agree.
Then we can move on to the rectal examination
Yes.
and see if there is any bogginess that can be felt.
Okay.
Can also do a pervaginal examination.
Okay. Other than a pelvic abscess, can you think of anything else on the 6th day when the patient presents with abdominal distension, fever, pain abdomen? It's because you are given the history that the patient is having a pelvic abscess. Okay, I'll come back to you. What is this cause of this pelvic abscess?
Is there any collected seroma which has got infected or any hematoma which has got infected or any devitalized tissue, maybe due to the rough handling of tissues intraoperatively?
You think that you will handle everything rough? Don't blame your previous surgeon. Every surgeon is wanting to do the good thing, isn't it? Can it be a missed injury? Can it be an iatrogenic injury occurring somewhere? The bowel being open your cautery injury?
Sir.
Is it an open surgery or a laparoscopic surgery?
Open surgery.
Open surgery. Still you can get an injury to the bowel and it could be leaking at that point of time. So how do you differentiate between a peritonitis at this stage and a pelvic abscess?
So usually the time of presentation would have been earlier than this.
No. If you are looking at a cautery related injury where there is a burn in a bowel, it takes time to present with peritonitis. The cut injury, you're right, it might present on the second day or the third day, but the burn would take time to leak. So usually they present, so you have to keep your options open at the 6th postoperative day. Patient was perfectly all right, patient was on feeds, bowels moved, patient was discharged. And I don't think any sensible person would discharge when the patient is having any problem. So something occurred after that. That also is a possibility. Okay, with this background, or it can be a subdiaphragmatic abscess. Okay, you are now doing a rectal examination and you have a pelvic mass. Agreed, pelvic abscess. How do you proceed?
So now we have to confirm the diagnosis.
Right? How do you go about that?
We can do an abdominal ultrasound to look for any collections in the abdomen. Then depending upon the size of the collection, depending upon the general status of the patient, and we can proceed further if you want to go for consult.
Can you be a little loud because I don't think we will be audible.
So first we'll do an
Ultrasound is done.
ultrasound abdomen to look for any collection, if it is present or not, depending upon the location and size of the collection.
3 into 3 centimeter collection in the pelvic region.
So the general condition of the patient is not.
Your patient.
We can go for an ultrasound guided drainage.
Does all pelvic abscess require an ultrasound guided drainage?
No, sir. If it is too small to be drained, then we can go for
So it depends on the volume of abscess cavity and, as you mentioned, the level of sepsis that you are doing it. You have to decide whether to interfere or not. Once you decide to interfere, what are your options?
So we can do a guided drainage, that is ultrasound or CT guided drainage, depending upon the
Okay.
location of the
Fine.
abscess.
Would you like to leave behind a catheter there?
Yes, sir.
What kind of a catheter?
Pigtail catheter which can
Pigtail
continuously
catheter.
drain the collections. Sir. And we'll start the patient on broad spectrum antibiotics.
Do you think that you can just put in a artery forceps through the closed vaginal cuff and drain this?
So that is also a source of external source of
You think that the infection will go up?
So at that point, there might be additions to the small bowel.
Yeah, you're not too sure whether there is any other bowel which is involved there. It's best to have an imaging, and the imaging guided drainage has to be done. So what was done for this patient in ED?
Laparotomy, re-exploration of the existing surgical wound, and extension of the and creation of a midline laparotomy wound, followed by open exploration and drainage of the abscess.
When do you think that this would be done by a gynecology surgeon? Who does it?
So if the size of the abscess is substantially large enough, like in this case, it was at
So
12,
the abscess is large in size,
the patient is stopped.
failed conservative management, failed drainage. You have attempted a catheter drainage, it failed, and the recurrence or continuation of the abscess cavity occurs, or you have signs of peritonitis coming in. Abscess cavity can actually, need not remain an abscess, it can rupture over a period of time. So, or when you are suspecting other causes and other things. So, we've done a laparotomy, right? So, laparotomy drained. What was drained?
So the pus was drained and a wash was given.
What did you do with this pus?
It would have been, it was sent for culture and sensitivity.
Okay.
So the report came back as Escherichia coli, which is sensitive to pip test. So the patient was started on, even before the culture report came, we had started our broad spectrum antibiotics, which would cover gram positive, gram negative, as well as anaerobic.
Okay, if you get, when you get any idea about starting a pre-op antibiotic, what antibiotic would you give?
So for laparotomies, we will mostly give antibiotics which would cover gram negative organs.
Right?
like E. coli and
Like which antibiotic is recommended as a perioperative antibiotic?
it's a third generation. This cephalosporins.
What is practiced in your unit?
Sir, we usually give cephalosporin in case of major lab problems. Cephalosporin sulfate.
What's the rationale of giving this perioperative antibiotic?
So we are looking for the organisms which are most likely to cause infection for a particular surgery, and we are giving them the antibiotic which covered that organism.
If you imagine that you have starting on ceftriaxone sulbactam combination, anticipating that that is the antibiotic which is going to be sensitive for the organism, if there is a sepsis after that, what is left over with you? What antibiotic is left over with you?
Let escalate to meropenem or
So that's not the rationale. Rationale is you should have a very narrow bit antibiotic which is generally not used for treatment of sepsis. So you should select an antibiotic which will cover a narrow spectrum which is the common organism. That is why every hospital does an antibiogram. The antibiogram is done for the kind of organisms that you get on an OPD basis as well as on an IPD basis, based probably on UTI and respiratory infection. And in majority of the sittings, you give a perioperative antibiotic with a very narrow band. The classical perioperative antibiotic is cefuroxime and cefazolin. These are generally not given for treatment of PUS. There is no point in trying to give ceftriaxone as your perioperative antibiotic because you lose your antibiotic armamentary with you, except when you have distinct knowledge that possibly biliary tract will be opened or GIT will be opened, your approach will be slightly different. But by and large, the principle of a perioperative antibiotic is this. Now coming back to your case, right? You've done culture and sensitivity, meropenem has been started on this patient. What happened after that? You've seen only an abscess cavity or something else you have seen?
Thickening of ileum just proximal to ileocecal junction.
Thickening of this ileum close to the ileocecal junction.
Proximal to IC junction.
15 centimeters proximal to the C junction. There was a inflammatory thickening of ileum.
Ileum was there. Only one segment. She's an young lady, isn't it? Very young lady. Suppose you have 3 segments or 4 segments of thickened ileum, would you have thought about something else? Why should this ileum be thickened?
So due to inflammation, probably due to the pelvic abscess.
So this is the taken up bowel along with the abscess, isn't it? So suppose there are other areas where there is a thickening of the bowel.
Suspect of Crohn's disease.
Yes, you have to suspect. Young patient, you need to suspect Crohn's disease. And Crohn's probably would have perforated and given rise to this abscess. You don't know. You don't know. So your finding has prompted me to ask this question. Okay. So if you have suspected Crohn's, what would you have done?
Sir, if it is Crohn's disease, we would see if it is an active disease or.
How do you know that?
So there will be fat stranding. There will be signs
Would
of.
you like to take a biopsy at this stage?
Yes, sir.
You should.
Yes.
Without opening into the lumen, you should take a biopsy. I'm not saying that this is Crohn's. That's not the idea. Since we brought up the thickened ileum, this thought process has to come into you. Okay. So there was only one segment which was taken up by the abscess area, and that you removed, and there was a thickening. Naturally expected. Okay. What do you think is the cause of this abscess formation?
Seroma which is collected, which got infected later on.
Okay. Okay. Then after that, anything happened to this patient?
Sir, feeding jejunostomy was also placed in order to decompress the bowel initially because the proximal small bowel was distended. And during the first 3 days, it was connected to an aspiration bag, and following which it was clamped and oral sips were started.
What is the rationale of doing this feeding jejunostomy of this patient?
It was mainly to decompress the bowel, so it was difficult to close the abdomen because of the distended small bowel loops during the laparotomy. So in order to decompress the bowel, they placed a feeding jejunostomy
What
proximal.
if you had done an enterotomy and bowel was decompressed and closed the abdomen? Before we go that, what are the conditions where you would like to keep this abdomen opened?
So if there was severe entire peritonitis was there.
So is this patient having sepsis? Those are signs of sepsis.
No, sir. No signs of sepsis.
There was no sign of sepsis except the demonstration of an abscess cavity. There was nothing to suggest sepsis. Patient tolerated an anesthesia and was fit to be extubated. Right?
Yes, sir.
Could you have, what is the physiological parameters by which you decide it's better to keep this abdomen open?
This is the serum lactate levels.
Okay, has it been done?
So we have taken an intraoperative ABG was done.
That is normal?
Yes, sir.
That's normal. So objective criteria are an ABG with a high lactate level, right?
And
by and large, the seniors would say that you should look at the abdomen from the tangential area, and if the bowels are sticking out, it's not a good abdomen to close. Right? That's your clinical feel. This patient is likely to develop a abdominal compartment syndrome. So, what is your objection against doing an enterotomy and decompress the bowel? And for further decompression, you pass a nasojejunal tube. Because jejunostomy has got its own set of complications, isn't it?
yes, sir.
If you are able to want to decompress the upper jejunum, what kind of a tube would you have passed? Would a rice tube come up to the upper part of the jejunum?
No, sir.
So what tube is placed for jejunal decompression?
Fracca maybe can.
Fracca tube. You have seen a fracca tube? What's the peculiarity of this fracca tube?
It's narrow with guide wire.
Narrow, it has got a guide. There is no guide wire, there is a steel wire, metallic wire inside that, which we need to pull it out because it has to be stiff to negotiate and thin calibered tube. So you can pass it across the duodenum to the jejunum. It is done for both decompression as well as for feeding, isn't it? Both can be, a fracca tube can be, in this particular case, an enterotomy and what is your objection against an enterotomy here?
Sir, the bowel is already inflamed and friable.
Yeah, you would have, if it had been a large, distension, you would have spilled it into the abdominal cavity. That could be one objection, but you could do it taking it out into the abdomen and drain it into the, whichever kidney tray or whatever it is, isn't it? So other than that, feeding jejunostomy at this particular point of time cannot be justified. It could be a decompression, and the purpose should be called as a decompression, not for feeding.
Yes.
When do you think that you would do a feeding jejunostomy?
On the proximally,
Not particularly this case. In your institution, for what all conditions would you do a feeding jejunostomy?
carcinoma esophagus with absolute dysphagia,
Gastric outlet
gastric
obstruction.
outlet obstruction,
Gastric outlet obstruction.
obstruction,
Okay.
post perforation for starting gastric perforation. If to start early feeds, we will do.
Perforation for starting early feeds.
How many times you have done a feeding jejunostomy for GE perforation?
Very rarely, not usually, unless there is a resection anastomosis more proximal.
So I would think that one feeding jejunostomy is where you cannot have food intake through the upper digestive tract. So it can be obstruction in the esophagus, obstruction in the stomach, so you have an excess down. Can it be for an early recovery from some operations that you do?
Yes, sir.
Esophagus to me, Whipple's restriction, where all your upper abdomen, upper gastrointestinal tree cannot be used early. For early feeding, you need to have a feeding jejunostomy. I hope that you know about different types of feeding jejunostomy and things like that. What happened to this patient after that?
So post-operatively, she was showing steady signs of improvement, no further fever spikes, and her loose stool settled. Brain output was progressively decreasing. And
What is the drain? Where did you put this drain?
pelvis in the
Pelvis. Taken out through
taken out through the lateral abdomen wall.
lateral abdominal wall. Why was it? Is it a necessity that you should put a drain after removing the abs?
Yes,
What for?
not to prevent any access for any recollection of the.
Need not be always. Need not be always.
And then also we have given a wash.
Yeah, a good wash is good enough because you have done an laparotomy, you have removed the whole thing. It is not necessary that you should drain the abdomen. The drainage of the abdomen, which previously used to be done for every opened abdomen, whenever you doubt you drain, that dictum no longer exists. One has to be very careful in putting a drain. Do you drain your DU perforation these days? Not. So when we were students, we were asked to drain every DU perforation. Today it has gone. Hardly we ever drain after this. So your attitude towards drain should be just redefined. Okay, what electrolytes would you be, abnormality would you be looking at these patients?
But hypokalemia, especially since it was she was put on a FJ aspirate, the bowel secretions would have been lost, which is rich in potassium.
So gastric, pancreatic, biliary secretions, which if it is coming out, you are looking at low potassium level, low sodium level, low chlorine level, chloride levels, all these things. What about calcium?
Calcium will also be.
No. High. No.
That we are not sure.
Some of the other electrolytes which have to be looked into are calcium and magnesium, particularly magnesium, because what's the normal value of magnesium level that you will be looking at? What's the normal value of magnesium?
2 to 4 milliequivalents.
So anything less than 1.8 milligram percentage requires a correction. How do you do a calcium correction?
Sir, calcium, we can calculate the corrected calcium levels of the patient. And then we can start IV calcium correction.
What calcium will be given as IV?
Calcium gluconate preferable.
Is there any other calcium preparation available?
Calcium chloride is also.
Chloride is also there. Usually calcium, calcium chloride is not given. The other calcium is given. How is it given?
For slow IV or
What if you give it fast?
arrhythmias,
What arrhythmia?
QT prolonged.
Yeah, sure. What if you give potassium fast?
So tall T waves will be there.
No, they are all physiological sense. These are two things which can stop heart, isn't it? What's the difference in the stopping of the heart between calcium and potassium?
Calcium will stop in systole and potassium will stop in diastole.
Yes, calcium stops in systole and potassium stops in diastole. This is utilized in clinical practice for the good of the patient.
During CAB open heart surgery.
So all cardiopedias are potassium-rich solutions. Potassium. Coming back to this case, you are forced to keep this abdomen open. What are your options? Why do you want to keep it open?
So we are suspecting the patient will develop an abdominal compartment syndrome.
Okay. How do you measure an abdominal compartment pressure?
So we can use you can empty the urinary bladder and we can introduce a Foley's catheter, and then keeping the you can use a
Bladder pressure.
bladder pressure.
Bladder pressure is measured. Okay. So, what would be the symptoms or what are the objective evidence that this patient is going to get in for abdominal compartment syndrome?
Decreased urine output.
Decreased urine output,
reduced, increased systemic vascular resistance, diastolic.
That we would have to measure. Clinically, when you are looking at the
Abdominal
patient,
distension will be increasing.
it can be increased, but need not be always increased. But what would be the predominant symptom of the patient? Low urine output.
Tachycardia.
Yeah, the patient is going to develop into tachypnea, isn't it? Tachypnea, worsening 7 minutes more. Okay. Worsening respiratory condition. The patient the work of breathing becomes more.
Yes.
The anesthetist, the oxygen requirement of the patient to keep the peripheral saturation would be high. And at given point of time, the ABG will show either a hypoxia, PaO2 will be low, or a PaCO2 is mounting up. So the patient may have to be put on respiratory support, isn't it?
Yes.
So, to prevent that, we have to do a open abdomen method. So you can just do a laparostomy and decide on. What are the problems of doing a laparostomy?
Post-operative infection rates will be higher in laparostomy.
Infection from exterior, you mean?
Yes.
There is a tremendous amount of fluid loss. There is a tremendous amount of protein loss. Temperature control will become really difficult because you have a large wet area, right? And if you keep it long, there is a chance of fistulations coming in, dried this thing and fistulations coming in. So your idea is to close this abdomen close this abdomen as early as possible, right? So apart from this elective cases, what are the other situations where you would like to keep abdomen open?
In trauma,
Damage control
surgery.
Are you really keeping it open, or do you do something else? You go for something called a temporary abdominal closure, isn't it? What are your options for a temporary abdominal closure?
Bogota and
No, that is an open abdomen. Temporary closure means you are closing and you want to keep it closed, but with a clear aim that you are going to reopen, isn't it? Bogota bag is where you keep the abdomen open. You put a sterile bag across. That's Bogota bag, right? You practically use urinary bag, isn't it? And keep it. Temporary abdominal closure. What are your methods of temporary abdominal closure?
tension suture.
No, tension suture is when you are making a formal closure. Temporary means that you know for certain that you are opening this in another 24 hours. Would you like to put a tension suture, then open it after 24 hours, then have a look, come back, and then again go back? No. Towel clips. You can use towel clips. You can use zippers, right? Whitman's patch, right? So those are temporary abdominal closures where you go for a planned operation within a few hours, usually 24 hours or maybe a little later than that, isn't it? So that's about temporary abdominal closure. Now this patient post-operatively, do you expect any problem for this patient?
Operatively, patient may have a
recurrence of what?
pelvic analysis if it is incompletely drained and the drainage.
Not incompletely drained. You have done a laparotomy. You cannot blame that there is a incomplete drainage. That's your problem. It can reaccumulate, but that's not incomplete. That's different, isn't it?
Yes, reaccumulation.
Reaccumulation can occur. Okay. Reaccumulation can occur, and usually that doesn't happen. So what is the long-term complication that you are going to face this?
Patients can
True with every intra-abdominal operations. Is she a candidate for development of an incisional hernia?
yes, sir.
What for?
Because our recurrent surgeries, one after the other.
One is she had a lower midline incision. She has a T-junction. She was done in an intestinal obstruction with a distended abdomen. She is done as an emergency. She had sepsis at the time of operation. So all these factors are against her, and she is a candidate for incision hernia. So you should anticipate that this lady is a likely candidate to come back to you or somebody else with an incisional hernia, right? Of course, chances of intestinal obstruction is higher, additions, etc. are higher, etc., etc. higher. I think time is up. If you have any problems to ask, you can ask. I hope that we have finished half an hour. We'll move to the next case. Thank you, both the candidates from Trivandrum, for a good show. Even a good hand. Thank you.
We've just finished the first half of the live session, the word rounds. And with this, as we shift on to the next patient.
If there are any comments from the seniors, or any questions, please come over. Yeah, come. Just come. Now we go to the second case. We go to the second case. It's a pre-operative setting. Team from Trivandrum Calicut Medical College. Sorry, Trivandrum Calicut Medical College is taking over. So you can make a presentation about this case. Come on.
Female.
It'd be good to have actress or a 45-year-old lady. I wouldn't like to call you as a, female. I'll call you as a girl. Okay? Go on.
Lady, present non-case of carcinoma. Non-case of carcinoma sigmoid, underwent sigmoidectomy and Hartmann procedure in 2021.
So let's stop. She had been diagnosed to have a carcinoma of the sigmoid and underwent Hartmann's procedure. Okay, fine. Was it done as an emergency?
Patient presented with a pericolic abscess. For that, she was taken for exploratory laparotomy and she went sigmoidectomy and Hartmann's procedure.
So, patient was preoperatively diagnosed as a pericolic abscess.
Yes.
So, what was the presentation?
She presented with diffuse abdominal pain.
I don't know about this case.
At that time, she presented with diffuse abdominal pain.
Diffuse abdominal pain. Did she have peritonitis?
No.
No peritonitis. Now let's imagine this patient comes to you with pain abdomen, 45 years. You make a diagnosis of a pericolic abscess. You made a diagnosis of pericolic abscess because there is only limited tenderness, limited area guarding, there is no peritonitis. What's your approach to this problem? If you are the operating, you are the receiving person, what you would have done? Would you have operated this lady?
I would have done an imaging first.
No, you've done an imaging, obviously, you've done an imaging, and that's how you come to a diagnosis of a pericolic abscess. Would you have operated this patient or?
The abscess showed air pockets in
naturally all abscesses.
It might pertain to a perforation.
Why should there be a pericolic abscess with perforation? And how do you classify this pericolic abscess?
The tumor may perforate and cause.
Why do you think that it's a tumor?
There's an enhancing lesion. There's an enhancing lesion.
You have an enhancing lesion, an enhancing tumor lesion, and that is connected to the.
Yeah, nearby the lesion, there is a connection.
There is a connection
with air pockets.
Okay. Still, would you have operated this patient? That's my question.
The collection has to. The patient needs definitive management. The collection has to be drained.
What if you give antibiotics?
The tumor is still there. The lesion is still there. Primary lesion is there. Unless and until.
So, what is the commonest cause of a pericolic abscess?
Diverticular.
Diverticular disease. How do you go about treating a diverticular perforation?
Exploratory surgeries.
Do you agree?
Yes. If it's perforation, we go with exploratory laparotomy and drainage. If it's
What about you? Chronic perforation, diverticular perforation with pericardic abscess. And I clearly got the opinion from you, patient is not in peritonitis. Would you operate or not? How do you classify these abscesses? Lynch classification. So it is not that a pericardic abscess always requires a surgery. That's the first question. That's the first thing. There should be overwhelming evidence to do emergency surgery. Pericardic abscesses are best treated conservatively unless and until you have generalized peritonitis, number one. When do you think that you would operate this patient, pericardic abscess, due to diverticular disease?
Failed conservative management.
Failed conservative management.
Features of peritonitis, patients have
General peritonitis.
Septicemia patient is going.
All septicemia related to general peritonitis. Would you do an elective surgery for this patient later on? That's my question. You must read the criteria for taking up this patient. Any patient above the age of 45 stands a distinct chance of knee perforation, even if they have escaped the first laparotomy. And what we have mentioned is your peritonitis, associated lesions. These are the indications to do a laparotomy and a excision. Mostly these are on the left side of the colon than on the right side of the colon, isn't it? So this patient had features suggestive of a tumor with a perforation. You operated such kind of situations, tumor in the colon with perforation. You've seen? You have seen. What is the implication of tumor perforation? Colonic carcinoma with tumor perforation.
Invasion penetrated.
Any idea? Perforated, there is a distinct, tumor perforation is a distinct entity. What does it mean to you? Is the overall survival altered by a tumor perforation? No. Overall survival is not affected by presentation either in perforation or with obstruction. Overall survival is not altered. But chances of local recurrence, chances of metastasis, all gets increased compared in a perforated tumor. Isn't it? Tumor perforation increases the chance of local recurrence as well as metastasis. But the overall survival is not affected by this. Is something which you need to understand. Right? Okay, so you have operated on perforation. What are the sites where you get perforation? Colonic tumor. Is it necessary that the tumor has to perforate?
Proximal, if there is obstruction.
So one is you can get the tumor site. Number two, get at the cecum. Perforation while you are treating a patient with carcinoma. What does it look? Because the question comes in because you have too many armamentariums to treat these days with. Too many armamentariums to okay, I think it's audible. It's now audible. So, is there a role for a preoperative treatment at any point of time in colonic malignancy.
Neoadjuvant chemotherapy to
Neoadjuvant chemotherapy, are they prone or are they making the colon prone to perforation?
there might be a chance.
No. Chemotherapy, does it make the tumor prone to develop perforation? Do you give radiotherapy in colon? No, you don't give radiotherapy in colon, you give the radiotherapy in rectum. Colon is a different. I'm asking, is there any drug which can give rise to a chance of perforation in a colon? Not chemotherapy. Are you able to think of any other agent that can be?
Enema,
You're right.
enemas, evacuenemas.
Yes, any angiogenesis inhibiting factors. You can give other things which make the patient, especially in the right colon, the choice of antibiotics that is given. You must read about right colon, left colon. There's a lot of difference in treatment. And on the right side, they are more prone to develop perforation while on treatment. So the tumor can perforate at the time when it is presenting, or tumor can precipitate. The perforation can precipitate at the time when the patient is on biotics. So this patient underwent a Hartmann's procedure. When do you think that you would do a Hartmann's procedure?
When you completely anastomose the patient has local peritonitis or the margins, you cannot bring down and do an anastomosis at the time.
Margins you can bring down because left colon, if you mobilize the splenic flexure, it will come down. But
It's too low for the,
yeah, so the issues are, number one, if the patient is having a hugely dilated bowel and the distal bowel, there is a gross mismatch. The patient is moribund, where you cannot afford to have an anastomosis. Patient is physiologically unstable with hypotension, lactic acidosis, while the patient is in sepsis. Such kind of situations, you don't want to do a prolonged surgery and make the anastomosis at risk. So you do a Hartmann's procedure, isn't it? So this patient underwent a Hartmann's procedure. Agreed.
in 2021, and she was started on 4 cycles of capecitabine chemotherapy. She completed it.
What is capecitabine?
The chemo. That's.
What is it?
Chemotherapy.
No, the drugs you must know. If somebody comes in, what's the drug you have told?
Capecitabine.
Capecitabine. What is that? It is a precursor of 5-FU.
Yes.
5-FU. So far, 5-FU has remained the cornerstone of treatment, or the most active treatment ingredient in all colonic malignancies, isn't it? What are the regimes that you use in colonic malignancy?
Capox regimen.
Capox. Classical regime is
Capox or Capox.
Yeah. Folfox
Or Capox.
and
Or
the drugs are what? 5-fluorouracil, irinotecan in one side, and 5-fluorouracil and oxaliplatin in the other. Leucovorin has come in between as a potentiator, right? And pre-drugs, how does 5-fluorouracil act on the, what is the principle of acting 5-fluorouracil? It blocks the thymidylate pathway of DNA synthesis. So there is the block. So the antimetabolite action comes in by preventing the replication, right? So they are the classical regimes. So what is given to this patient?
Capecitabine is 4 cycles.
Is it justified to have a single drug, drug as a regime? Justified when you have renal compromise, when you have hepatic compromise. I don't know whether she had one to start with, right? You have a pathology report of this patient?
Yes, pathology.
What is a pathology report?
But the pathology report shows patient T2N1B disease.
What is the stage T2N1B? What is N1B?
2 to 3 lymph nodes.
Not 2 to 3, 1 to 3 lymph nodes. 1 to 3 lymph nodes is N2B. N2B, okay. So what's the stage?
Stage 3.
3, what?
Stage
What's the stage? T2N1B is stage 3B.
B.
Classical type. Okay, stage 2B. So stage 2B requires adjuvant treatment in the form of any 5FU based, and if the patient has got moribund renal liver compromise, you can resort to a single agent chemotherapy. Fine. That is justifiable. Let's not question it. What about the normal status here? You said N2B. How much was harvested?
12 lymph nodes were harvested.
Are you sure? That is because yesterday Dr. Mathur apparently has told you that minimum of 12 is required.
So 8 were harvested.
8 were harvested. 8 were harvested, and how many of them were positive?
3 of
them were positive. You think that it was so we had one suspicion, was it necessary on a clinical ground? Now, was it adequate surgery?
No.
No. So we could have converted this surgery into a more elective surgery. We could have made a better surgery, isn't it? I'm not trying to blame anybody, but then from the history and from the pathology, was there a tumor perforation here? Why do you say it's a T2? Tumor perforation to me will become a T4. You said pathology is only T2. So
tumor has not penetrated.
So how does it perforate? You only told me. I have no idea about
Necrosis of the.
No, even then, it's a T4 disease. If it is tumor perforation, has the tumor perforation been noted separately or not in the pathology report?
The tumor has not. Invades into muscularis propria and subserosa. Serosa is free of tumor.
Serosa is free.
of tumor.
So, was it a tumor perforation to start with?
There is no evidence.
There is nothing to. Clinically, there is no evidence. Pathologically, there is no evidence. Right? Pathologically, no evidence. What happened to this patient? So, this is how you should look back and say that whether you could have done it. I'm not trying to criticize with this thing, but you yourself should have understood that doing this slightly differently would have made, made a better outcome of the patient, isn't it? Okay, fine. What is the mitotic status?
No, special studies.
No. P53 may not have been done. Here, the differentiation, you look at the differentiation.
Well differentiated adenocarcinoma.
What is the mitosis that they have described per type or field?
They haven't mentioned regarding.
So well differentiated is very unlikely to be having. Yeah. What other pathological feature you would be looking in such kind of patient?
Lymphovascular invasion.
Lymphovascular invasion.
Perineural invasion.
Perineural. Were they present?
No, sir.
They were not present. They were not present. Okay. Any other thing, prognostic factors would you like to see in this patient? Pathology? No. Tumor markers, we'll come to that a little later. Anything else would you like to, in a chronic malignancy, would you like to see something in the pathology?
Protein marker.
Like?
MSH1, MLH1.
What does that mean?
HNPCC.
No. I was looking at on the treatment part of it. Have you heard about MMR?
Proficient MMR and deficient MMR.
What does that mean?
Proficient MMR is the protein which has there is a protein. There is a protein from the gene. Deficient means there is no protein expressed from the gene.
So in that, is there a mutation that is reported here?
Only P53 is reported.
P53 is mutation is there, otherwise no mutation. So the patient is sensitive and will respond to 5FU. So there are 20% of the patients who are deficient in this, and these patients should go for a second line chemotherapy rather than. So though lot of information you get it from the pathologist. So here there is no mutation that is detected. The repair pattern is good. The patient should have responded to 5-FU. So there is a point in putting this patient with a combination chemotherapy rather than on just a single line chemotherapy. Okay? So that's how you look at the dissect your pathology completely. So your staging, your clinical presentation, your pathology are not matching. Right? Okay, fine. Now what is the patient's problem? And after that, what happened?
Patient was on follow-up. They took a repeat CT.
Follow-up with what?
After chemotherapy,
How many cycles were given?
4 cycles,
4 cycles were given.
She went in 2020, she underwent reversal of anastomosis.
Reversal of
Hartmann's.
Hartmann's was done.
Hartmann's was
When was this done?
Jan
After the chemotherapy.
after 4 cycles of chemotherapy.
What are the objective criteria by which you would say that this is the time that you want to do a reversal of the Hartmann's? What are the things would you do?
Patient CEA levels will look.
Okay, your tumor markers should show that there is no elevation to suggest local recurrence or metastatic disease or luminal recurrence. Fine, excellent.
Distal tract.
You need to
Yes,
assess the
the
distal
distal tract.
tract. Distal tract. What is the reason for that?
If the distal obstruction, you cannot anastomosis. You need to address the distal obstruction first.
For 2 reasons. Number one is you must know the level of the upper end, because very often we are taught to put a hitch stitch when you do the Hartmann's and keep it there so that the next dissector, whoever it is, whether you or not, you can easily identify that. So you must assess the length of the available segment. Number 2, it is disease free. So number 2, number 3.
Adequate length of the distance. Adequate length of the distance.
That is why you have done a
Distal
proctoscopy or a sigmoidoscopy or a radiological anastomosis with distal. What about the proximal? This patient had an emergency surgery. Do you know whether the proximal tree has got any other lesion?
Loop color.
You can just have a look at it. You do a colonoscopy, isn't it? You can have, what do you want to look at there?
Any lesion, any other lesions.
Any other lesion. You must know what is metachronous, you must know what is synchronous. Is that all what you require? Polyps. Polyps. Okay, polyps. All those things you will get. So you study both upper end and the lower end, tumor markers, and well condition whether the patient can undergo a fit process after chemotherapy, So whether her cardiac status, respiratory status, nutritional status, everything is good. So she underwent a reversal. It was a perfect reversal and everything went on. What happened after the reversal?
After the patient, August 2023, she presented with right-sided abdominal pain.
Did she stop at 4 courses of chemotherapy?
After reversal, she underwent 4 cycles of capecitabine again.
Again. So what was the hurry to, do this reversal without completion of chemotherapy? Absolutely no hurry. Because to me, she would have been better treated with complete course and then reassess. Because time will take for certain things to evolve. Right? Okay, fine. Okay. Ultrasound abdomen you have not done. Do other liver metastasis or anything of that kind. Or maybe if the tumor marker, there are situations where tumor markers may be low, but you still have reasons to suspect metastasis. Okay, right. So she underwent 4 cycles more of chemotherapy, was given again the same capecitabine. Then what happened?
On August 2023, patient presented with right-sided abdominal pain with recurrent UTI. CT was taken.
The The patient presented with right-sided abdominal pain. What was the clinical finding? Right-sided clinical pain, was it urinary tract infection? Why do you say right-sided abdominal pain and she was diagnosed to have urinary tract infection?
Patient were underwent URI.
No. When the patient comes to you 6 months later, you say that the patient has got right-sided abdominal pain. What makes you to think that there is a urinary tract infection? Is that your first diagnosis? No. So when did this urinary tract infection come into picture? Did she have fever, chills, fever, or anything, or dysuria to suspect urinary tract infection? Okay, fine. How was the urinary tract infection diagnosed on her? Did they do a urine routine?
They must have. I didn't.
They must have.
They
done.
must have done.
They must have
Have
done.
done it.
Okay, when do you think that you would say that's a urinary tract infection by looking at the urine routine and saying that 2 RBCs are there and 1 pus is there?
More than 10.
Yes, more significance for the RBCs than for the pus. Many of the ladies, she must be postmenopausal, isn't it? How old is she?
45.
45, postmenopausal. Anyway, elderly, 5 minutes more. Okay, fine. So it would be, elderly ladies can have urinary tract infection. So urinary tract infection is there. Agreed. What do you want to do now?
Patient is
You
also
are not necessary. You don't have to look at.
for this patient. I would go for imaging for the patient.
What is there in your mind?
There may be metastasis or local
How
recurrence of
does
this
it
patient.
preclude to the diagnosis of urinary tract infection? Your primary thought process came from your.
There might be deposits along the ureter. There might be a compression the ureter. Right.
You know the diagnosis. That's the reason why you're thinking like that, isn't it? Why should somebody have a urinary tract infection with a right-sided abdominal pain? Do you think of a deposit in the right abdomen? Okay, anyway, you did a ultrasound.
CT had been done for the patient.
You don't believe in doing an ultrasound?
For this patient, it has been done.
If it had come to you, would you have done an ultrasound? Or
My first line would have been
would be an ultrasound. Or should be an ultrasound, no doubt about that. So they have done a CT, or ultrasound would not have been given to you because CT had some findings they have given to you. What is the CT finding?
CT finding had enhancing lesion, nodular lesion in the right iliac fossa, which is compressing the ureter.
Right iliac fossa.
Right.
Does ureter come in the right iliac fossa?
Right lower abdomen.
Right lower abdomen. Use your terminologies very correctly. If I am to say ureter doesn't come in the right iliac fossa. Straightforward. So right lower abdomen, there is a pelvic deposit. That encases the ureter. What about the hydronephrosis?
Patient has right moderate hydroureteronephrosis.
Moderate hydroureteronephrosis. What about the characteristics of this lesion? No mention about
No
it.
mentioning
How much is the size?
I was not given. They have given
They have
enhancing
nodular lesion. Is there any other lesion elsewhere in the abdomen?
No, complex. Other than that, there is some cyst, complex cyst, and right kidney.
No, liver is free. There is no free
Here,
fluid.
CLD.
The liver is, as far as, so far the picture of cirrhotics has never been brought into the picture. She underwent 2 surgeries. Did she have cirrhosis in the initial ones? In a matter of three, 4 CTs you have mentioned. One preoperatively, one below at the time of reversal, and in between.
Nowhere it was mentioned.
The cirrhosis is a new picture. Have you contributed to the cirrhosis by your treatment? You don't know. So I wouldn't like to believe that she is restrict time being. We'll take it with a pinch of salt because there is nothing has happened in the last 2 years. I don't think she has indulged into heavy alcohol in the last 2 years to cause this. So I'll take it with a pinch of salt, right? So read everything carefully. So CA is
Normal.
normal. So CA is still normal. She has got a pelvic deposit. And let's for discussion, let's say that this is a tumor deposit. Do you have any reasons to say that she is a likely candidate? She is a likely candidate for a tumor recurrence.
She's a right candidate for
Why?
treatment.
Why?
Margins, the resection was in first place, margins were not satisfactory.
You didn't tell me that. Why was it not satisfactory?
There was less than 0.2 centimeter clearance.
So initially itself the surgery was questionable. The surgery was untimed, not timed well. Surgery was inadequate because the resection margins were inadequate. Normal clearance was inadequate. She had presented with perforation. She had all the reasons to recur. Isn't it? All the reasons to recur. So can you salvage her or not?
You can go for to look for any other lung metastasis or anything.
Nothing is there.
We can proceed. If it's an operable lesion, we can proceed.
They have not mentioned anything about the size of the lesion, local infiltration.
They haven't mentioned.
Is that fine with you? No, I'm worried about her kidney. I'm worried about the kidney because kidney shows hydronephrosis, isn't it? So is this kidney salvageable?
With the report, I am not able to.
So when do you think that you will, what would you like to see in the kidney?
There is parenchyma loss.
What? Cortical thickness. You need to look at the cortical thickness. Cortical thickness. How much cortical thickness is accepted? 15 millimeters. Cortical thickness is a candidate which can be salvaged on the kidney. Right? That is not an objective evidence. It only says that there is a thickness. You don't know whether it's functional or not. So what investigation would you like to do? DTMSA scan, any one of them would say what is the functional status of that kidney. You have one more problem. You have an infected, obstructed system. You said it's a urinary tract infection, isn't it? So would you like to discard this kidney even if it is TMSA shows that it is a compromised kidney? No. Infection can deteriorate the renal function. So you need to drain the kidney and see whether it is recoverable or not. You can do a percutaneous nephrostomy, allow the kidney to recover. Meanwhile, you can assess the operability and go ahead with an operation, because if it is around the region of the bladder, if it is operable, you can remove a cuff of bladder, allow the kidney to recover. Ureter is adequate in length. If it is, what will you do? You have a resected bladder, you have an end ureter.
Ileal pouch.
Ileal pouch. Your opposite kidney is there. Opposite, opposite kidney is draining well. It is already done with the bladder. Bladder is functional well.
Ureter.
You can anastomose the ureter to the bladder. At the best, if it is coming, you can raise a Boris flap and put this thing. So I think I'm told that the time is up. I think they also had a good discussion. Give them a round of applause. Thank you very much for patiently listening. If there are any questions or comments, please come. So thank you, everyone. Thank you. Thank you. Thank you.
Thank you, sir. It's a brief round of the board rounds, the live telecast. We come to the end of this session. May I invite the chairpersons for the next session, Dr. Sarvottam Nedungadi, Dr. Jose Kamliar, Dr. Rajan Janardhan. We've also been told that Dr. Satish Balasubramanian will be joining us shortly. We have the case presentation, right hypochondrial mass by Government Medical College, Alapi, to be presented by Dr. Rahul Unikrishnan and Dr. Jayalakshmi. May I request the chairpersons to kindly come and take their seats on the dais, please. Once again, we expect Dr. Satishan to join us shortly. Over to our experts now.
Good morning, everyone. Myself, Dr. Jayalakshmi, and
Rahul Unikrishnan.
we are presenting a case on right hypochondrial mass. First of all, history of presenting illness. Presenting the case of 63-year-old male from Edatwa, studied till 10th standard and is a manual laborer. Presenting complaints include abdominal pain for 2 months, loss of appetite and weight for past 2 months, and cough for 1 month. Patient complains of dilating pain in the upper abdomen, insidious in onset, which is progressive over the past 2 months with no aggravating or relieving factors. There is no radiation of pain to back. It is not associated with food intake. He also complains of loss of appetite and loss of weight for the past 2 months. Regarding bowel habits, there is no history of vomiting, constipation, diarrhea, no history of blood in stool, blackish or clay-colored stool. There is no jaundice. He also complains of cough, which is non-productive in nature, no hematitis, no history of nocturnal dyspnea or orthopnea, no history of fever, no history of chest pain, back pain or seizure. Past history, there is no history of diabetes, hypertension, tuberculosis, asthma, cardiac diseases, allergies or jaundice. No past history of any medications, no past history of any surgeries. Personal history, he's having a non-vegetarian diet, he's a smoker, 3-pack PD per day for 28 years, and he's an alcoholic, 1 bottle toddy 3 days per week for 28 years. His bowel and bladder habits are regular and sleep is normal, appetite is reduced. Family history, born out of non-consanguineous marriage, no history of malignancies or tuberculosis in family.
General examination. The patient is conscious, oriented and cooperative. ECG score 1. Moderately built and nourished. Height 162 centimeters. Weight 61 kilogram. BMI of 23.2. No pallor, ictus, clubbing, cyanosis, generalized lymphadenopathy or perineal edema. Skin, hair and nail appears normal. There is no supraclavicular lymphadenopathy and there is no stigmata of liver failure. The patient is febrile, pulse 10 beats per minute, regular, normal bone and character, no vessel wall thickening, no radial or radiofemoral delay. Blood pressure of 110/70 in sitting position in right upper arm. Respiratory rate 15 per minute, abdominal thoracic, SpO2 97 on room air. Inspection. If illness is not in the right hypochondrium and epigastrium, extending to the umbilical region, the umbilicus is central and normal. The skin, there is no scars or sinuses. There is no dilated veins, and all organs move equally in respiration, and there is no visible peristalsis. The hepatic size appears normal. The external genitalia appears normal. There is no renal, angle or left supraclavicular fossa pronounced. Palpation. There is no local onset of temperature or tenderness. The mass of size 10 to 13 centimeters is palpable in the right hypochondrium, epigastrium and extending to the left hypochondrium and the umbilical region. 7.5 centimeter in the right from the right subcostal margin in the right mid-alveolar line and 10 centimeter from the episternum, and it moves with respiration. The swelling have nodular surface, hard in consistency, lower body sharp and well defined, upper body is not palpable, and not able to insulate the fingers between the subcostal margin and the mass. Para test identifies the intraperitoneal swelling. There is no splenomegaly, no renal tenderness, no other non-palpable. The hernial sites are normal and external genitalia is normal. Percussion, there is a liver span of 17 centimeters in the right midclavicular line. Upper border of the tenderness is not in the right fifth intercostal space. Dullness of the lung is continuous with the liver dullness. The top space is resonant and there is no free fluid noted.
Auscultation, vowel sounds normal and no breathe. Little examination, normal sphenical tone. Rectal mucosa appears normal. There is no bleeding. Fecal staining. Prostate is normal. There is no intra or extraluminal mass palpable. Clinical examination, respiratory rate 15 per minute, abdominal thoracic and regular, shape of the chest is normal, respiratory movements are equal, position of trachea central, air entry bilaterally equal, and normal vesicular breath sounds. All lung areas are resonant and percussion. And the cardiovascular system, S1, S2 heard, the numbers, central nervous system, higher mental functions, motor system, sensory system, reflexes are normal, and there is no focal neurological deficit. Central system, skull, spine, long bones appears normal. Okay, summary. A 63-year-old male with no non-comorbidities or past surgical history, presence of abdominal pain, loss of weight and appetite for the past 2 months, and a recent onset cough with no hemoptysis for the past 1 month. On examination, a mass of size 10 into 13 centimeters palpable in the right hypochondrial, epigastrial, and extending to the left hypochondrial and umbilical region. 10.5 centimeters in the right from the right costal margin in the right midclavicular line, 10 centimeters from the sternum, and it moves with respiration. The swelling has a nodular surface, hard in consistency, lower border is sharp and well defined, where the upper border is not palpable, and it moves with respiration. Not able to insinuate the fingers between the subcostal margin and the swelling. No on percussion, the liver span is 17 centimeters. Dullness of the liver is continuous with the dullness of the mass. Diagnosis, probably is a case of hepatomegaly, probably liver secondaries.
So, did you mention jaundice in your past history? Did you go through?
Yes, sir.
Is it important?
Yes, sir. Yes, sir, it's important.
What type of jaundice predisposes to primary malignancies?
Sir, hepatitis is a risk factor for hepatocellular carcinoma.
Which hepatitis?
Viral hepatitis B and C.
B and C. Okay. So why do you say this is clinically secondary liver? What is your points in favor of your impression or provisional diagnosis?
Sir, in history, there is loss of weight and appetite, and which could indicate of a malignancy. And on examination, there is a right hypochondrial mass which moves with respiration, and it is hard in consistency, and it is irregular, involving both lobes. And the dullness of the mass is not continuous; it's continuous with liver dullness, so indicating of a liver malignancy. And the edges are sharp, sharp bone.
Okay. Did you find out a primary? Why do straight away you said it is secondaries?
And the most common type of liver swellings, liver malignancy is secondary.
No, clinically you have said that right at the beginning, after your clinical examination, you have said that it is secondaries. Why do you say on clinical exam, you haven't done any investigation, but based on the clinical findings, what makes you conclude that this is secondary liver, not primary liver malignancy?
So first, it involving the both lobes of liver and
okay, it is a diffuse enlargement.
Diffuse enlargement, and the lower border is sharp.
Okay.
And it is well defined and a hard consistency.
What is the surface like?
Surface is irregular.
Irregular?
Or nodular.
So what is a clinical feature that you can make out where you can distinguish between a primary and a secondary, or a macronodular cirrhosis and a secondary? Why can't this be a macronodular cirrhosis?
Sir, the edges would be smooth.
No.
What is sharp?
Actually, there are certain points to distinguish between a primary and a secondary. Suppose it is a single nodule, that is more in favor of primary. Multiple nodules, more in favor of secondary. Anyway, if there is a history of primary, okay, most likely to be secondary. If there is an umbilication of the nodule, that is more likely to be secondary. If it is a hard nodule, that is more in favor of it being a secondary. If there is a broe, that is more in favor of a primary. What are the classical clinical points to make a diagnosis of liver? When will you say that a swelling in the right hypochondrium is liver?
The anatomical location and the right hypochondrium. Then the swelling is moving with respiration.
Moving very well with respiration.
And the fingers, the upper border is not palpable, and we cannot insinuate the finger between the lump and the subcostal margin. And the dullness of the liver is continuous with the liver dullness.
It will not be bimanually palpable or palpable, isn't it?
Yes, sir.
Can you tell me what are the points, what are the anatomical attachments that keeps the liver in the right hypochondrium?
Falciform ligament, cardiac ligament.
Apart from the triangular ligaments and falciform ligament, it is the attachment of the hepatic veins to the inferior vena cava. That is the most important force that keeps the liver in the right hypochondrium. Why in the history you have asked about jaundice? Why you have asked about jaundice? Will it, suppose if the patient is jaundice, will it order your management?
Sorry, jaundice can predispose, like hepatitis can predispose to
If the patient is in the decompensation stage, you may not venture a resection in those cases.
So what are the stigmata you look for the liver diseases?
Sir, signs of jaundice.
One is jaundice.
Parotid swelling, parotid
swelling,
gynecomastia, then palmar erythema, spider navy, Dipinger's contracture, ascites, testicular atrophy, caput medusa.
Okay, fine. So in the spider navy, how many crops of spider navy should be there to say that this is prognosis? It's a progressing disease.
5 to 6.
No, I think it's more than 9 fresh crops. So is spleen palpable here?
No, sir.
No. So what are the differential diagnoses of localized swellings of a liver?
Highlighted.
Yes.
Highlighted said a primary liver malignancy, HCC. Then amoebic liver abscess or liver abscess.
Liver abscess.
Then a hemangioma.
Hemangioma highlighted. And focal?
Focal nodular hyperplasia.
What is focal nodular hyperplasia?
It's more common in females.
Okay. So you missed Riddle's lobe also.
Riddle's.
So what is Riddle's lobe?
The anatomical variation, it is an extension of the
Please, close to the...
extension of the right lobe of liver down the subcostal margin, which is
Yeah.
an anatomical variation.
Yeah. What is the significance? Clinical significance of Riddle's lobe?
It can present as a mass in the right hypochondrium, but it's a
It
normal.
comes as a differential diagnosis. You have to rule it out. Okay. So is there ascites? No
No, sir.
ascites.
Any other possibilities that you can think of that this is a secondary? Either in the symptomatology or in the signs. You said it's a secondary.
Yes.
So what other clinical questions would you like to ask the patient?
Questions. Sir, since secondaries, liver secondaries are most commonly from a colorectal malignancy, so a bleeding per rectum, constipation.
That's my point. You have got to think of where the primary is located once you get so huge a secondary in the liver. So that is anticipating you may question the patient on the possibility of any other primary sites.
Sites.
So what are the different types of secondaries?
carcinomatous, carcinoid, melanomatous,
Yes.
like sarcomatous.
Sarcomatous and lymphomatous. So can you clinically suspect a melanomatous secondary by examining the patient?
No other skin lesions or
There were no other skin lesion in this patient.
Sorry?
There is no other skin lesions.
Skin
There-
lesions?
No skin lesion in the patient.
No. So absence of something? Missing something?
toes and glassy
Missing toes and
Missing toes?
glassy eyes.
glassy eyes.
Yeah, very good. Okay, fine. So what are the other places from where carcinomatous secondaries can occur apart from colorectal?
Stomach,
Stomach,
breast,
breast,
then prostate, pancreas,
yeah,
then
pancreas.
melanoma.
Right.
Depending upon the time of occurrence of the secondaries, the liver secondaries are classified into
Synchronous, metachronous,
precautious, synchronous, and metachronous.
metachronous.
Which malignancy is notorious to produce a metachronous liver secondary?
colon,
Malignant melanoma.
melanoma.
Can you tell me what is the microscopic extension of a liver secondary beyond its macroscopic limits? That is a liver secondary.
Yes, sir.
You are doing a hemicolectomy for a lesion in the cecum. You have seen a nodule in the liver. What is the possible microscopic extension of that nodule beyond the macroscopic appearance? It's approximately 1 millimeter only. That is why you can do a fracture resection if it is a single secondary. Another important thing is when you operate, most of this time, these liver secondaries will be on the surface of the liver than on the deeper aspects of the liver.
All right, Dr. Rahul. Now, how will you proceed further? You got a clinical diagnosis of secondaries in the liver. What are your next steps? Proceed the.
First, I will like to confirm the diagnosis. Get
Okay.
a first USG abdomen imaging.
Okay.
In USG abdomen, we can look at the liver, whether it is a secondary or a primary. Then intrahepatic biliary artery dilatation, that is if there is biliary obstruction. Then portal vein involvement can be looked. Then ascites.
Okay, you will do a imaging, ultrasound first. Would you proceed still further as far as imaging is concerned?
Yes, since it is since we could not correctly define a primary, we get a CCT of the abdomen, thorax, and the pelvis. Then, since colonic malignancies are more common, endoscopy, upper GI and lower GI endoscopy, colonoscopy.
Just a minute. You were thinking of a secondary and you said primary could be from the colorectal thing. So after the imaging investigations, would you rather go for all those higher things or would you rather go for a simpler endoscopic evaluation?
After the imaging.
After imaging, ultrasound, you're still going to see so many other investigations. But before that, a simple investigation in the form of a endoscopic evaluation to either detect or rule out a primary.
Sir, imaging can help us to stage. If it's a malignancy, it will also help in staging the disease. And we can also look for a lymph node involvement if any is present. Yes, we. Since you will also go for an endoscopy.
So what is the role of CT scan abdomen?
CT scan.
So you did ultrasound. That is a basic imaging. So what advantage is to do CT scan in this case?
Usually since it is liver, we will go for a triphasic CT. And in triphasic CT, we can differentiate between a primary hepatic or a secondary. Then we can look for any other primary malignancy in the abdomen, if it's a sort of pancreas, stomach, or colon. Then,
so what are the differential diagnoses of a diffuse solely liver? What are the differential diagnoses?
macronodular cirrhosis.
Macronodular cirrhosis. That can be detected. Right.
And then liver secondary.
Secondary.
Then if there is a cardiac disease, chronic cardiac disease.
No, liver. It cannot be liver. Nodular cirrhosis liver. Polycystic disease can occur. Can polycystic disease of liver can occur? Yes or no?
Yes.
Doubtful.
Yes.
Okay, so multifocal primary can also.
Multifocal primary scan.
So many things that can be detected much better than CT scan, because CT scan pick even the smallest tumors, less than 1 centimeter. So what is the role of MRI?
In fact, if you are you expecting any further information from an MRI? Or you just are satisfied with whatever I got?
MRI.
You are not sure.
So MRI can give you a tissue diagnosis of one thing. Second, involvement of the hepatic vein or involvement of the portal vein can also be seen. So MRI is also very important before planning for resection, any resection also.
However, CT and MRI can be used to assess the functional vessel volume of the liver also.
Considering this is a second wave, what treatment options you are planning?
First we should look for the primary. First, and the endoscopies can help. In the endoscopies, if primary is located, the biopsy can be taken, and this would put in a stage 4 disease. And usually the treatment of stage 4 is usually palliative treatment. And in the colorectal,
primary could not be identified.
If it's a carcinoma of unknown primary, then if there is a diagnostic dilemma, we could take a biopsy from the liver biopsy, it could be throat biopsy, and check for the IHC markers of liver.
How do you take a biopsy? FNAC or
Throat is better since it can be used for IHC or genetic testing.
It's true. How do you do it? When there is a diagnostic dilemma, you are justifiable by doing a biopsy. How do you do a biopsy?
Shiga needle.
Shiga needle is there.
Zimmerman.
Zimmerman needle. What is the third one? So how do you prepare for this biopsy? How do you prepare the patient for biopsy?
Vitamin K injection are given. And
before that?
Before PTNR, APTT evaluation.
You should check the coagulation profile.
And LFT to look for
apart from LFT definitely. But coagulation profile should be corrected. Then vitamin K, how many days you give? What is the route of vitamin K administration?
IV vitamin K.
Sorry?
IV vitamin K.
IV vitamin
And there is
K.
IM also preparations vitamin K.
No. Usually vitamin K injections are OID injections, so we give IM injections, but IV is also available now, vitamin K. Okay. So what are the complications of your voice?
There can be hemorrhage, then there can be metastatic needle tract metastasis.
This is multiple liver secondaries, isn't it?
Yes, sir.
Which are the primary malignancies, the secondaries of which if you resect it, gives very good results?
Colorectal malignancy.
Colon and kidney. You can also resect neuroendocrine secondaries also. But nowadays actually the scenario is changing. Even secondaries from other malignancies also they are treating. They are trying to resect it because there are various other modalities of treatments are there. The chemotherapeutic agents which can downstage these tumors and all. So the tendency towards resection is increasing and decreasing.
So what are the treatment modalities for secondaries, unknown primary secondaries?
Sir, we could proceed with the IHC and the usual panel which is given are CK20, CK7, TTF1 and NAPSIL. And CK20 are usually infradiaphragmatic, could indicate a colonic malignancy. CK7 is supradiaphragmatic. Then TTF1 or NAPSIL indicates an adenocarcinoma, usually lung. Then PSA can be sent to look for a prostate malignancy. And since NIHC could indicate a site, we could then proceed with a site-specific therapy, which are chemotherapy agents. And if it's a colorectal malignancy, FOLFOX regimen is used. And gastric malignancy also, systemic chemotherapy, FLOT regimen. And in lung malignancies, cisplatin-based regimens. And in lung, there is immunotherapy and targeted therapy is also available.
Targeted therapy is also available. So anyway, good. Dr. Madhumurali is going to tell you in detail in the next topic. So wait for that.
Thanks.
Thank you and congratulations to both the PGs. I invite Dr. Madhu Murali next, please. Thank you.
Good morning, respected chairpersons. Just to add to what was being discussed over here, I think the students missed out on one point, that is tumor markers. Serum tumor markers should come high up in the sequence of investigation of a liver secondary. So that can give an idea whether you are going towards the CA side or CA19-9 or CA125. So tumor markers, one investigation missed out. So can I have a slide, please? So this is a topic about hepatic metastatic and level in complexity. Those who have listened to my talk during the ASI peripheral meet, for them it would be a repetition, but I think it's good to repeat because it reinforces. And again, it's an important topic because there are 3 sessions exclusively dedicated for liver in this particular CME. One is my talk, second is by oration, it is coming just after this, and there is a Prathapan's talk coming on liver metastasis. So liver secondaries and operating on the liver is a very important topic because if you look at the global trends, the incidence of metastatectomy, so surgeries done for metastatic liver disease has been on the rise for the last 2 or 2.5 decades. It is reflected in our own database. Why so? We understood that all stage 4 is not palliation. Natural evaluation of a malignancy from early locally advanced stage 4 disease, because before it becomes stage 4 extensively disseminated, there is a phase called oligometastatic disease. This is where the surgeon's role comes in. Now, if you have oligometastatic disease, it is no more palliation, it is a curative intent. So we have to define what is oligometastatic disease within the spectrum of metastatic disease. So it is, theoretically you can say that any metastatic disease
where you can attain R0 resection. When I say R0 resection, it is combining surgical resection with ablative procedures. It can be from radiofrequency ablation or microablation. So you can attain R0 resection, it is a curative metastasis. But you have to come down to some objective way of defining it, which ESMO stated that 2 or 3 sites, 5 or less lesions, and visceral nature, like lung, liver, or even spleen, can be subjected to or can be defined or can come within the gambit of what is called oligometastatic disease, and they are not palliation, they are for surgical resection. And now, as Gamal also rightly said, can it be applied to all malignancies? No. We have definite evidence that this concept of oligometastasis and surgical resection or R0 resection can be applied to two definite malignancies given in green, colorectal cancers and neuroendocrine tumors. But as you go towards the other end of the spectrum, I change the colors to red because there are some data that you can do metastatectomies in sarcomas, germ cell tumors, even in breast cancer. There are large data saying that metastatectomy can be done in breast cancer also, but it has to be oligometastatic. Gynecological cancers, pancreas, stomach, esophagus, I put in red because there can be anecdotal reports. But colorectal cancers and neuroendocrine tumors, we all should understand that all is not palliation. There is a disease called oligometastatic disease where you can surgically go ahead and resect these lesions. Now I'll focus much on colorectal cancers, and if time permits, I'll go on to other malignancies. Now how do we go about it? We have understood over the years that they give us excellent results. Can I have a pointer, please? If you look at the graph, you can see that stage 4 liver not resected, the survival is dismal. But if you can resect a stage 4 liver, the survival is as good as operated stage 3 liver. So stage 4 oligometastatic liver, if operated, will give the same survival as stage 3 disease. And the 5-year survival can touch up to 40%. You're talking about a patient who can be operated and given life to 5 years life of 40%. Now, what if you don't operate these patients? Don't operate and give only palliative chemotherapy, systemic chemotherapy, the 5-year survival is less than 5%. But if you can choose out your patients, select the oligometastatic disease and offer surgery for them, your 5-year survival is 10% or your 5-year survival is 29%. That's what I say. So if you can choose out these oligometastatic patients, you operate them, you can get good results. Now, how do you get into these patients? As was discussed in the last session, you have to have a stringent follow-up of all your colorectal cancers. Surgery and adjuvant chemotherapy doesn't end the treatment. You have to keep this patient CA follow-up and once in a while ultrasound every 3 to 4 months for the first 2 years, every 6 months for the next 3 years. So recurrences can occur up to 5 years. So during this 5-year period, you have to keep this patient stringent follow-up, and any rise in CA should warn you or ring the alarm bells, and you initiate subsequent investigation in the form of a CT scan, colonoscopy or PET scan, and pick up these lesions which are oligometastatic and then take them for a curative resection. That's where we go for. Now, before going into the concepts and how to sequence the therapy, I'll give you some snippets or some small capsules which can help you in taking decision on metastatectomy. So, what are the basic concepts of going ahead with a oligometastatic? First thing is that every other patient is not a case for metastatic. You have to choose your patients properly. There are certain factors based on which you can choose your patients for metastatic. That is, number of tumors in the liver. Extensive metastasis, no, 3 or 4 metastases or up to 5 metastases can be subject to metastatectomy. Size of the largest tumor, 4 centimeter, 5 centimeter, the larger the tumor, the outcomes are bad. Of the CA value, very high CA value, the outcomes are bad. Lymph node positivity, the outcomes are bad. Disease-free interval, the more the disease-free interval, the better. For example, patient had a colon cancer in 2020, comes with a recurrence in 2021, it's bad. But it comes back with a liver recurrence in 2025, it's better. So the longer the survival, the better the patient. So based on these factors, you have to choose your patients, and if you can choose your patients, you can give them good results. Now, just as was Gamal sir again mentioning, what is the margins that you should be giving for a metastatectomy? Again, we have long-term data that it is just negative margin that you're aiming at. And so you need not go for a 1 centimeter, 2 centimeter margin. So if the tumor size is big or a functional liver remnant is going to be a challenge, a negative margin resection is all what you need to attain. So anatomical resections are not needed. The randomized controlled trials looking into anatomical versus non-anatomical resections, it has shown that non-anatomical margin negative resection, not about 1 centimeter, just a negative margin would suffice. The fourth point I'd like to share is that, as was discussed again in the previous session, I think, or the session which we had the ward rounds, the liver of the patient after chemotherapy showed signs of cirrhosis. So understand that all these patients would have received chemotherapy for the primary tumor and it would be FOLFOX. FOLFOX is toxic on the liver, and the patient who has received 8 or 10 cycles of chemotherapy would have what is known as chemo-associated liver injury or chemo-associated steatohepatitis. So the more the number of cycles of chemotherapy the patient has received for the primary, the more the chance of patient having a post-operative liver dysfunction. So these are the factors which you should take into account when deciding on how you go about resecting patient. Now, in a normal liver, what needs to be left behind is 20%. But if the patient has received chemotherapy, at least 30% of the residual liver should be left behind to have a functional outcome. And if the patient is cirrhotic, you need to have more liver. So based on these calculations, you should look into the factor whether I'm dealing with a patient with a normal liver, chemo liver, or chemo plus cirrhotic liver. So these are the factors which will help you to decide on what extent of the liver can be resected in a metastatectomy. Now, again, we should understand that surgeons, we should understand that giving chemotherapy prior to liver resection has got its own complication. The more number of chemotherapy you give, liver metastasis can disappear. This is one of our own patients, I think, because you can look at that. There are 3 lesions actually, but this patient received chemotherapy and you can see that one of the lesions have disappeared. And once a lesion disappears, it's a problem for the surgeon because they have disappeared on the CT scan, but they are not disappeared pathologically. So you will have to identify that lesion and you have to resect that lesion. It is in that context that, as Rajan sir was asking, MRI comes in. If CT doesn't pick up, go for MRI, try to find out the disappeared liver metastasis by some means, and you will have to operate on that patient. So disappearing liver mets doesn't mean that it has disappeared pathologically. It just means that imagologically it has disappeared. You have to surgically resect that. Now, the last other point I would like to share is that, can you do simultaneous resection of the liver and the colonic cancer? Usually the answer is no, because you don't want to combine a major colonic surgery with a major liver resection. But there are situations where you can do it combinedly. Specifically, if you're a good laparoscopic surgeon, you can do laparoscopic sigmoid resection or a laparoscopic colonic resection with a laparoscopic liver resection. You can do it. So the problems of access is not there. But generally, the concept is that do not combine 2 major surgeries together, especially if it's a left-sided lesion. But right-sided lesions with small liver lesions, there is data. The METASYNC trial showed that small lesions can undergo simultaneous resection of the colonic primary as well as the liver resection. But mind that the liver resection in these patients were less than 3 centimeters. So occasionally we take up patients for simultaneous resections, for example, transverse colon or a right-sided colon with a small lesion in the left lobe of the liver. You can go for simultaneous. But general concept is that don't combine 2 major resections. Sequence the treatment. Now, so the guiding philosophy is that do not combine 2 major resections. Patient's general condition should be good enough to undergo both the surgeries together. And as I said earlier, laparoscopy has solved the issue of access to a large extent. Now, coming to how would you, with this basic concept in when we should understand how can we sequence the treatment. For example, if you have a synchronous lesion is defined as a diagnosis, early metachronous within 12 months and late metachronous is more than 12 months. So each of these has to be dealt with separately. Now, if you have a metachronous lesion, that is you are already treated and cured the colonic primary and patients come back with you with a what you say like a liver lesion, and then it is much easier to treat the patient because they would have presented a rising CEA. You evaluate the patient with CT scan or a PET scan, and then you find them that they have a metastasis. Easy to treat because there are 2 ways you can treat this patient. Very simple. So first is that if it's an easily operable lesion, you can give 3 or 4 cycles of chemotherapy, go for the liver resection and complete the chemotherapy. Even if the patient had received chemotherapy for the primary sigmoid, there is a rule for secondly treating with chemosystemic therapy. So give 3 or 4 cycles of chemotherapy, go for the liver resection and complete the sequence. But if it's a borderline operable liver lesion, here you will have to combine a 3 to 4 cycles of chemotherapy, which will be a biological agent based on the mutation analysis. And then still you can convert a borderline operable liver into an operable liver and operate the patient. So this is pretty much easy because you need not worry about the primary, which has already been taken care of. But the problem comes when you have a patient who has got a colonic primary along with a metastasis, because here you will have to operate the liver, operate the primary, and somewhere put in chemotherapy also. So the question comes, how can you sequence the treatment? So I'll put it very simply. There are two situations. One is an asymptomatic colon with an operable liver. Symptomatic colon with an operable liver. Hope I'm clear. So if it is symptomatic colon, it's again easy because you have obstruction, perforation or bleeding. You have to address that first. So operate the colon first, put the patient on chemotherapy, bring back the patient for liver resection, and then finish off the chemotherapy. I don't want to complete all the chemotherapy here because, as I already said, the more the number of chemotherapy you give, the difficult the liver resection is. So here you would go for something like a sandwich therapy. So this is an easy scenario. But the more difficult scenario is when the colon is asymptomatic. There is no obstruction, there is no bleeding, and there is an operable liver lesion. Here there can be different opinion in the multi-tumor board between the medical oncologist and the surgeon, because as a surgeon, I want to operate at least one of them. Either way. But the medical oncologist would always say that the patient is asymptomatic, I would challenge him with systemic chemotherapy and then decide how to go about it. But the point is that you have to take a call. So I give you three scenarios how you can operate, go about managing these patients. First is classical. As a surgeon, I want to operate one, and preferably I will operate the primary first, colonic resection, chemotherapy, come back for the liver resection, finish the chemotherapy. Here there is a concept known as switch therapy, where again, if I think that I can operate the liver first, I'll go for liver resection, finish off the chemotherapy, come back for the colonic. But the only problem here is that the colon may become symptomatic during this waiting period. Otherwise, liver switching is a liver first or primary liver first is an option. But the medical oncologist would say, any of these is good for you. Starting off with chemotherapy, operating one of them, again this. So again, this all comes down to discussing with the medical oncologist or on the surgeon on one side, and which is more convenient to the patient doing that. But I would say the one that we prefer is colon first, chemotherapy, liver second, finish up the chemotherapy. So these are the three options how which you can tackle a patient who has got a synchronous presentation with an asymptomatic primary. Again, I have been emphasizing on this because there is no data to say that starting off with chemotherapy offers a benefit over liver first or colon first. Anything can be done. Any of those combinations are evidence-based and they can be applied to your patients. So coming to hepatic metastasis in neuroendocrine tumors, again, here is a role where the spectrum expands. Every other patient can be subject to metastatin provided you can, even the metastatin need not be 100%. Even 70% cyto reduction is acceptable in a neuroendocrine tumor because you have other armamentarium that lutetium therapy, etc., which can be taken, which can take care of the residual disease. So when it comes to neuroendocrine tumor, there is a role for a R1 resection or even R2 resection as per as liver resection concerned, because if there are multiple lesions, take out the ones that you can take out, leave the small ones behind, which will be taken care of by the lutetium therapy, which you give as adjuvant therapy. Lastly, hepatic metastasis in breast, which would be surprising to most of us because there is some data that if you choose your patients, you can have a 5-year survival of 50 to 40% because no other systemic therapy can give you 5-year survival of 40% or above in breast cancer. So there is a role for liver metastasis in selected patients. I just bring the concept. That doesn't mean that all liver or breast cancer liver metastasis should go for metastatectomy. Lastly, as I said, it's not about surgery alone. You have to combine your surgery with other modalities, like if there are 4 lesions, 3 of them can be easily resected. One is a deep parenchymal lesion, which is less than 1 centimeter. That can be tackled with radiofrequency ablation or microwave. So you have to sit along with an interventional radiologist, take out the ones that you can take out, and if the small one which cannot be taken out or with a difficult location, close to hepatic veins, you can't take it out. Just ablate that lesion by RFA or microwave. So by combining surgery with ablative methods and systemic therapy, the spectrum of metastatectomy or dealing with metastatic liver has been expanding over the years. So it has just an exciting area to operate on. So to conclude, stage 4 is oligometastasis, and not all stage 4 is palliation. Multimodality treatment combining surgery with ablative methods and systemic therapy can offer you a survival of about 45% or even to 50%. But the key points are that choosing your patients based on various factors and the sequencing of the treatment, I think I have explained that, and ablation and interventional modality should come in handy when dealing with liver metastasis. Thank you so much.
The session is open for the audience. 1 or 2 questions.
Madhu, you in your definition you mentioned about the sites and lesions.
Yes, sir.
What is the difference? You mentioned it as 2 or 3 sites or 4 or 5 lesions. What is the difference?
Again, so please don't go by the numbers. I just want to convey that number is not a limiting factor. For example, we had patients with liver and lung metastasis with a colonic primary. So what we do is somehow say there is one lung lesion, 2 liver lesions, not palliation. The 2 liver lesions you can excise, the 1 lung lesion you can excise. So any situation where you can attain R0 resection, resect those lesions and have a good functional outcome. The patient should be having a very smooth post-operative recovery. So it's not about the numbers, it's about the resectability and the number of organs involved. So ESMO has come out with the diagnosis that less than 3 organs, less than 5 lesions, and larger size of tumor should be less than 4 cm. But again, I don't think we should stick to that numbers very strictly. You can have your expanding those indications.
Good morning.
Sajid,
excellent talk.
Thank you, sir.
As usual.
Thank you.
Perhaps a little bit out of the relation to your talk also, but then we had a short discussion before in the ward rounds.
Yes, sir.
In which discussion on a patient who had undergone a colostomy, and following which the patient had taken a chemotherapy.
Yes, sir.
And then Dr. Santosh sir had asked,
why
should we close the colostomy, finish off the whole therapy and then close it, or should we close it before that?
So the basic concept of any chemotherapy is that if you are scheduled 6 or 8 or 12 cycles of chemotherapy, do not break that chemotherapy for more than 3 weeks or 4 weeks. For example, previously we had the concept of sandwich therapy in breast cancer. Today, I don't think any center practices that, because the longer the duration between 2 chemotherapies, the effect comes down. We have data for that. That is why, if you have a situation where you can finish off the chemotherapy, 6 cycles, 8 cycles, 12, whatever the schedule is, finish off that chemotherapy before taking up the patient for stoma reversal. But I'm not against early stoma reversal, but you can close the stoma immediately after surgery if there is no leak or if an anastomosis is going to, and then start off the chemotherapy. Because chemotherapy can be started as late as 8 to 12 weeks. You need not start off the patient adjuvant chemotherapy within 1 week, 2 weeks, or there is data say even starting chemotherapy for 8 weeks is as good. So the general concept is that if you have planned X number of chemotherapy, try to finish off unless there are pressing needs to reverse that chemotherapy. Because as Santosha rightly said, before closing the chemotherapy, you have to make sure that the patient is disease-free, which can be done only after completion of systemic therapy by means of CE assessment and colonoscopy. So all those things would suggest that do not stop the chemotherapy unless you can make sure that you reverse stoma and get back the patient for the next cycle of chemotherapy within 3 weeks of time, which is a bit difficult, I believe. That's
Also, if we are giving radiotherapy, also I think that problems of colitis and things like that also can be taken care.
Yes,
much
stoma,
better.
so basically the concept of radiotherapy has shifted from post-op to pre-op. So today we don't have many patients receiving post-operative radiotherapy. If there is indication for radiotherapy, it's pre-operative. That's in rectum. So if the radiotherapy has been given, you can reverse, then you operate. I don't think that will interfere with the decision to timing of a stoma reversal.
Thank you.
We are running short of time. So 2 more questions from the audience. One is Dr. Srikumar.
Madhu, regarding your disappearing liver metastasis, see, we had a patient, colonic primary, synchronous metastasis, bilobar multiple. I think she received 4 cycles of Volfox, and CT scan shows only 2 lesions. So you said you would do an MRI and chase the original.
Yes.
Original CT.
Yes.
The MRI again does not pick up the original lesion. So what do you do in RCC?
So what we had these situations where even the MRI has not helped up. Then we have 2 more options. One is to go for a PET scan, which may show up the functional residue. Still, you are not able to find out the disappeared liver meter. The 4th option is to go for intraoperative ultrasound. Intraop, you plan for the surgery anyway. You have 2 lesions which you already decide to resect. Go for resection. Intraoperative, try to identify the lesions which were there pre-chemotherapy and try to. But there have been occasions when even the intraop ultrasound has not helped us to identify that disappearance. We leave it and see after 3 months. That's all.
One more question, please.
It's about the. It's a comment about the preservation of liver parenchyma in colorectal mets, because these patients go for multiple chemotherapies, and nowadays road for major resections like you have mentioned ALPS, which is not very commonly done.
Yes.
Nowadays, more often it's metastasectomy with intraop RFA and microwave and preserve the parenchyma. That approach is more preferred unless it's a major large
Yes,
liver
yes.
mets. And second question was about the same thing about
Disappearing.
disappearing liver mets, which you have. Thanks.
See, so the concept of radiofrequency ablation in a palliative way, it's fine. But if you're looking at a curative intent, any sorts of ablations would be effective only if the tumor size is less than 3 centimeter or 2.5. So you can use ablative methods for tumors which are less than 3 centimeter or 2.5 centimeter. Beyond that, it offers only palliation.
What
Am I right,
about
sir?
lesions which are deep in the parenchyma where
Yes,
it
sir.
otherwise would result in major
Yes,
liver
very
problems?
close to the middle hepatic vein where you may end up with the extended right or extended left. Those are the areas where we have problems. Yes, sir.
One more. It's
Yeah.
not a question, it's a doubt.
Thank you, sir.
As you said about the resections.
Yes, sir.
And we have two criteria following. One is Milan's criteria and one San Francisco criteria. And Milan says less than 3 numbers and less than 5 centimeters diameter you can go for resection.
Yes, sir.
And other says a total of number is not important. Number of secondaries are not important, but the total diameter should be less than 8 centimeters. What is that? Could you
So the
please
Milan
clarify?
criteria or your the criteria are basically for primary liver malignancies in a cirrhotic liver, decide whether resection versus ablation versus transplant. So they don't play out in the field of metastatectomy because, as Prakash sir said, most of the metastatectomies are not very large, provided the patient has been on a good follow-up. Because if the patient has got a rising CEA, you can pick it up at 10 or 11 rising CA, immediately subject the patient for ultrasound, CT scan, PET scan, and most of the metastases picked up are less than 5 and less than 4 centimeter. Very rarely we have metastases which are 10 centimeter, 11 centimeter, very rarely, unless the patient has been lost for follow-up. So the points that you mentioned are not for metastatic, they are for deciding on whether the patient good for resection procedure, ablation, or a transplant procedure in the context of a primary HCC or in the concept of with the background cirrhosis. So metastatic, these numbers don't apply, sir.
Okay, thank you. Thank you very much.
Thank you, sir. Thank
for
you.
your
Thank you.
wonderful talk.
Thank you so much.
And we are going to.
Thank you, sir. May I request Dr. Sarvatman to kindly hand over a certificate to our esteemed Dr. Madhu Murali, please. And may I request the other chairpersons also kindly join in. For all the PGs participating in the e-poster competition, you're kindly requested to report at the conference hall at 11:45 a.m. The poster presentations will start at 12 p.m. For the selected postgraduates, conference hall is on the ground floor. Dr. Nesa will coordinate. So kindly contact her. All the PGs participating in the e-poster competition to kindly report to the conference hall at 11:45 a.m. Thank you. Preparations are going on for the M.L. Dattan Memorial Endowment Lecture. The prestigious M.L. Dattan Memorial Endowment Lecture is next. We request all of you to kindly take your seats before the lecture starts. And kindly, the oration requires you to kindly be silent. Put your phones on silent or vibratory mode, please. Once again, PGs participating in the e-poster competition, kindly report to the conference hall at 11:45 a.m. Dr. Unisa will coordinate. A warm welcome to all of you once again. We have the prestigious M.L. Dattan Memorial Endowment oration now. Picture of Dr. Dattan on screen. May I request you all to put your phones on silent mode, please. And we'll announce the dignitaries onto the dais. May I invite the chairman, ASI Kerala chapter, Dr. Srijan, onto the dais, please. The national office bearers, may I invite Dr. Muhammad Ismail and Dr. P. Rajan, please, onto the dais. Secretary, ASI Kerala chapter, Dr. Madhu Murali. The Treasurer, ASI Kerala chapter, Dr. Zulfikar, also on the dais, please. It's my honor now to invite the chairman, Dr. Srijan, to kindly announce the oration, please.
Very good morning to all. I request Professor E.V. Gobi to occupy the chair. Please come to the dais. This is a very important event along with the CME program of the ASI Kerala chapter. Dr. M.L. Dattan Endowment Lecture. This is instituted in the name of Professor M. Leeladhara Dattan, who had been present in all the ASI conferences of Kerala. He was Professor of Surgery at Trichur Medical College, and after retirement he was there at Jubilee Mission Hospital. He was the secretary of the ASI and the chairman of the ASI. He was a very great teacher, and this year the Professor M.L. Dattan Endowment Lecture is awarded to Dr. E.V. Gobi, who was Professor and Head of the Department of Surgery at Calicut Medical College, and he was a principal last year at Calicut Medical College, and he was a past chairman of ASI Kerala chapter. I request Dr. Santosh John Abraham to read about Professor M.L. Dattan. Thank you.
Good morning to all. Professor Leeladhara Dattan is a native of Varkala and a classmate of Professor Dayand Babu sir. Got trained in MBBS from Medical College Trivandrum in the year 1965. He did his post-graduation from the same institution and went on to UK to get his fellowship from the Royal College of Surgeons of Edinburgh. He had a short stint in UK, following which he returned to Kerala, joined the medical education services at Trichur Medical College as a lecturer in general surgery, spent most of his career at Trichur Medical College, and went on to become the professor and head of the department, Government Medical College, Thrissur. He was a great surgeon with special interest in gastrointestinal surgeries and has done quite some research in the field of gastric cancer, which was endemic in and around Thrissur during those days. He had a vision to develop the department even when he was a very young surgeon. He was a clinician, great academician, and an administrator par excellence. Many surgeons in the current era were trained, guided, and nurtured by Professor M.L. Dattan. He was a great mentor, was extremely proud of his juniors and really wanted them to do better than him, and he used to enjoy learning from the juniors too. His mentorship is worth emulating. He was secretary and later became the chairman of the chapter and has immensely contributed towards the academic activities and building the association as of date. After his retirement from Government Medical College at Trichur, he joined Jubilee Medical College and has continued his services there until his untimely death in 2014. He is survived by Professor Sudha, his wife, Professor of Pathology, son who is in US, and a daughter who is a radiologist practicing at Palkad. Dr. M.L. Dattan Memorial Endowment Lecture was instituted in memory of this great surgeon, academician, and mentor for all of us in ASI Kerala chapter. Thank you.
Thank you, sir. May I now invite the Secretary, ASI, Dr. Madhu Murali, to kindly read out the citation which will be presented.
Citation, Dr. M.L. Dattan Memorial Endowment Lecture 2023. Dr. E.V. Gobi. Born in 1961, Professor E.V. Gobi did his MBBS and MS from Calicut Medical College. He joined the Medical Education Service in 1991 and worked in the Department of General Surgery in various capacities before becoming the professor and head of the department of Calicut Medical College in 2016. He became the principal of Government Medical College Calicut in 2022 and retired from services in 2023 after an illustrious teaching career spanning over 3 decades. A good team leader, a motivator, and a guide to many, Professor E.V. Gobi currently is a professor of surgery at KMCT Medical College, Calicut. His tenure as head of the Department of General Surgery at Medical College, Calicut is considered as one of the most vibrant periods of the department. He started various specialty outpatient clinics in vascular surgery, diabetic foot OPD at Calicut Medical College. Professor E.V. Gobi has been an undergraduate and postgraduate examiner to various universities and National Board of Education. He has also been the chairman and coordinator for undergraduate and postgraduate examinations at Kerala University of Health Sciences. Professor E.V. Gopi has been an active member of ASI and has been the chairman of the state chapter for the years 2022 and 2021. Mr. Chairman, I have immense pleasure in presenting Professor E.V. Gopi, who has aptly been chosen to deliver the M.L. Dattan Memorial Endowment Lecture for the year 2023 on his chosen topic, Frontiers of Liver Resection, during the annual CM of ASI Kerala chapter at MES Medical College, Perinthalmanna.
Thank you, sir. May I invite the chairman now to honor our orator with the medallion. The M.L. Dattan Memorial Endowment Oration this year to be presented by Dr. Professor E.V. Gopi. May I request all the dignitaries to kindly join in. Kindly put your hands together, ladies and gentlemen, for this prestigious medallion. It's now my privilege to invite Professor E.V. Gopi to deliver the oration.
A warm good morning to all my friends and students. First of all, I would thank the state leaders, Dr. Srijayan ASI Chairman, Secretary Dr. Madhu Murali, and RRC Chairman Dr. Santosh Jodabram, and the Secretary of today's conference, Chairman, Organized Chairman Dr. Jose Kameli, and convener Mohammed Ismail, and Secretary Asif, and all-rounder Dr. Captain Siddiq. Today I am standing in front with immense pleasure and happiness because I am so proud being honored by this, offering this prestigious lecture or oration regarding our former professor of surgery, Dr. M.L. Dattan. Yes, I started my career in Calicut Medical College. This is my alma mater. I entered this campus through this gate during the 1979 November 17, and left through this gate 2023 May 31st. I spent almost 41 years in this campus. That's it, 2/3 of my life in this campus. It's a glimpse of look on people who I am remembering or in my life, that is Professor A. Tyagarajan. He motivated to become a surgeon, and his they can say if there is a cool anesthetist and bold surgeon, no contraindication for any surgery. His service still very active. Next personality is K.P. Rajagopalan sir. He is a wonderful surgeon. He is a very meticulous surgeon and famous for thyroid surgery. He can enjoy his surgery just like enjoying a music. Other personalities not with me, Fasil Markaz. He taught me how to send the articles to for publications, how to evaluate the thesis, and always remember the great personality of Fasil Markaz. Next to another giants, Dr. Andaba sir and Dan sir. Then sir is always, I am following his books before the class for PGs and undergraduates. And Dan sir is the known among the PGs all over India. And during the COVID session, I conducted a Kerala Surgery PG clinics. That is, these two people finally their comments and concluded all the 12 topics is there. I am assured that No question will be asked beyond that in this surgery. PGs can follow these classes in YouTube. It's available on YouTube. 12 topics. These are two young people. Sundar John, he only made me to become the member of the ASI as well as the member of the, I will become the chairman twice. That is in the history of ASI. I am the only person to get ASI chairman twice. And he also appointed me so many times in national conference as a chairperson or evaluator of the poster or a part of the RCC. And Sri James, he's also concerned with teacher in esophagus. I consider esophagus surgery in the Calicut is before Sri Jain and after Sri Jain. So I learned so much from Sri Jain. Luckily, I was in S4, he will be in the S6. So I am major day, his day is minor. So we'll discuss each other. He helped a lot. And over the period, I replaced esophagus by right colon twice and transverse colon once. Only because of his, so he's a teacher to me, and he's a well, he's a administrator. He's helped a lot during my principal period. Ranks are also one organization. He visited twice in the principal period to bless me on the end of the my career. This is my shock observations in life. My wife and my son is an engineer, my daughter is completed anesthesia, and the son-in-law is also just joined the surgeon. And you come to the topic proper, that is a frontiers in liver resection for a general surgeon. My mantras for overcoming the frontiers are, you should overcome the frontiers by love the liver, know the liver, choose the liver, respect the liver, and believe in liver. Common frontiers, our inhibition. Inhibition is most of them is a very vascular organ, largest organ in the body. How can touch the inhibitions and anatomy and its variations. Proper selection is very important. Intraoperative challenges. Your liver surgery are ready to accept anatomical variation at any time. Managing postoperative sequelae also. How I ventured into liver surgeries. Actually, two incidents. Either by coming in contact with the liver and fascinated the surgery of liver. First one is, this is one stay and then famous picture. The Swiss God cursed the Prometheus who brought the fire to human beings. He was being chained to the Olympus mountains, and every day the eagle will come and eat a part of his liver. The next day, liver regenerates. So they have the knowledge that liver has immense capacity to regenerate. And Babylon is considered a seat of soul. Malayalis also considered a seat of love. If you are love too much your girlfriend or somebody, you will call as a quarrel. First successful elective liver resection by Langenberg during the year 1888. True anatomical right hepatectomy by Laurent Jacob 1952. Large non-anatomical wet resections now possible because modern techniques and technologies available. I ventured into liver surgery. That is thanks to an era when we are nicely operated just before just basic investigations and X-rays. This is a story. The one patient was admitted, 8-year-old lady. She was my classmate's grandmother. She presented with the features of gastric outlet obstruction, the resonant epigastric mass, moving with the respiration. And that time there was no CT or ultrasound available, and she was not willing for OGD. She posted for surgery. For surprise, peroperatively, the stomach was smiling to me. This intact, normal stomach. a huge hanging swelling from the left lobar liver. What should do? I cut the using cautery and suture the vehicle, cut, suture, cut, specimen removed. And send the pathology. This is the first specimen calculated medical sarcoma of the liver. The surprise. So I tried to know more about liver. Another is I was very fortunate to get one of the rarest of rare presentation which liver itself can present with to me. This is the OP ticket of O4 unit, date 28/7/2008, Shahar Banu, G3P2L2. I was that time CMO. Now it is changed. Now this CMO is junior most fellow, Luteum Vadamo is a senior. No, during that time, senior most is the CMO. So I was CMO, and about 2 or 3 I was called to attend the IMCH for gynec operation theatre. I was always happy to attend the gynec court, IMCH, because there will be small addition to the ovary, very small addition to the apparatus or small tear in the serasa, and they will make a scene that surgeon is coming. So, so one sister is ready with the mask, another sister ready with the cap. Everybody is alerted. So I know that nothing will be there because. So with happiness, and end of the they will give a fine coffee and snacks also. That way the HOD, most of them my teacher also. So I enjoyed all the calls from IMCH. So this time also I attended the call. The searching for the ectopic. Ecto was not there. So I just peeped through the shoulders, and nothing is there, virgin abdomen. And ultrasound, some shadow in between the, something between the lower pole of kidney and the pelvis. Nothing is. So I changed. I entered the theater. This is the picture, surface. Anybody can guess what it is? So, this is another picture of that. So I ended, I also searched for the ectopics. Ovary is normal, uterus is normal, nothing is there. I extend the incision vertically and find a bluish mass from the medial to the gallbladder and close to the IVC, a bluish color. I thought as being as hemangioma. So I tried to aspirate. I expected blood. The white fluid is coming, not the blood. So I thought it is a headache cyst. So I packed well. So I am happy in my mind that I am going to operate a headache cyst in the gynec OP. So packed all the areas, and I poked repeatedly my suction to the hemangioma. One leg is coming. Second, another leg is coming. It was a baby. This is the pool of blood. I could see the gallbladder there. This is the gallbladder. This is the pool of blood. Pointer. And you could see the placenta and cord structures. This is the baby. So this I delivered the baby. It's a male baby. You see the umbilical cord. This is the placenta is there. And this is the baby. At the pediatrician operated, it won't survive. So you discard the baby and packed the hole with a big, not the mop, towels, 2 towels, and packed and left. And the next day shipped to the NMCH. After 48 days, removed the pack. Patient discharged without any problem. So I started to read much about the liver. Come to the surgical anatomy of liver. First, there's a quiz. There is a question that coineal segment. Liver is left liver means 2, 3, 4. Right liver means 5, 6, 7, 8. And the line passing between the cantilever line, the principal planes, tip of the gallbladder to the right of the IVC. That's the principal explained. That is dividing boundary with the right liver and left liver. Or you can teach the segments with your right hand like this, with the right sushura, middle sushura, left sushura. Right contain right hepatic artery vein, left middle contain middle hepatic vein, left hepatic vein, and umbilical pressure between the these two fingers. So you can teach easily the segments of the liver. Each segment dual vascular inflow, biliary drainage, and lymphatic, that's known as portal carriage. Boundaries of each segment, venous outflow by hepatic veins. This is for surgeon. This is the line is already mentioned. There is a line of Canley. You can this is always you can assess where is the line. You give in minds where is the right liver and left liver. This is another picture. That is the blood supply is 1.5 liters per minute. 80% from the portal vein, 20% from the hepatic artery, but oxygen supply is 50-50. Most consistent features of biliary and hepatic artery anatomy is inconsistency. You are always expecting him going to see without a chartage, you're going to see without a chart like that. You are anytime you can expect anatomical abnormality, whether biliary, arterial, venous. These are part and parcel of liver surgery. These are certain anatomical abnormalities. Normal liver is only 55% is normal anatomy. So that 45% is abnormal, arterial, biliary, and venous anomalies. The most important, why there is anomalies there? This right hepatic artery may arise in the superior mesenteric artery. Left hepatic artery may arise in the left gastric artery. What is the reason? Reason is very simple. In the embryologically you can explain. In the embryo, 3 hepatic arteries. Right hepatic artery arises in the superior mesenteric artery. Middle hepatic artery arises in the ciliary trunk. Left hepatic artery from the gastric, left gastric artery. That is why these anomalies are developing. So, surgical point of view, when you are doing a Whipple resection, always palpate the posterior aspect of the CBD before dividing a CBD. Or doing a total gastrectomy, you always like it close to the wall of the stomach in the left. Otherwise, you may compress the blood of the left lobe. These are 10 variations. Important variations I mentioned. Close the liver, another point. Proper indication you should assess. Proper pre-operative evaluation also very important. Is it amenable to surgical resection? Is the feature liver remnant is sufficient for the life? Quality of feature liver remnants. Choose the liver. It could be malignancy, benign, or others. Malignancy is liver tumor, commonest hepatocellular carcinoma, cholangiocarcinoma, metastasis, and other malignancy like gallbladder, other organ like a transverse colon malignancy infiltrating. Benign tumors, commonest benign is hemangioma, adenomas, RPC, Caroli's disease, hydatid cyst, and liver cyst. Others liver transplant or in liver trauma. This is a picture of MRI, this left lobe and right lobe. This intrahepatic cholangiocarcinoma classification, right, is the 4 classifications. This is one metastatic tumor excised by me. This is from the colon. Common second, as Madhumali mentioned, common is colorectal, next neuroendocrine tumor, and GIST. And or you classify into GIT and non-GIT metastasis. Because GIT is prognosis it's better than the non-GIT metastasis. This is a gallbladder infiltrating into the liver exercise. And benign, the hemangioma, giant hemangioma more than 10 centimeter, maybe paid signs of inflammatory process, compression, bile duct, stomach, thrombocytopenia or rupture. A young female present a casual with paper-thin pallor, paper-like pallor, it may be rupture fatty adenoma or ectopic pregnancy. And there is a cystadenoma, contains ovarian-like stroma, high risk of cystadenoma, carcinoma in this case. Next, adenoma, there is more than 8 centimeters, malignant signs for 5%. So, the liver. In an indicated patient for liver resection, proper preoperative assessment is needed. Is it amenable to surgical resection? You should ask yourself, is the feature remnant is sufficient? Quality of feature liver remnant. Basic investigations, imaging and tumor markers. Imaging contrast CT abdomen, pelvis and chest. MRI liver is sometimes required, CT angiogram. And PET scan if you are operating PET, secondary liver. PET, otherwise PET is not indicated. Then tumor markers. Alpha fetoprotein, CA99, CA, and protein induced vitamin K antagonist 2. It is raised even the metastatic liver also. It is not available here. Basic investigation, already mentioned tumor markers and biopsy of the liver tumor. Biopsy is not required for liver, see, operable liver resection biopsy actually is a contraindicated tumor tracking. So it can produce a spread of tumor, just like operable head of pancreas or testicle, there are biopsies, even the major cases, biopsy is not required for this. This is a normal anatomy of the liver. This is one of the specimen operated by me. This is normal right and left, no abnormalities. We always discuss your investigation in the radiodiagnosis department. Then you get a correct idea. This is the portal vein anatomy. This is a right anterior portal vein and the right posterior portal vein and left branches. Is this another view of the venous and portovenous system, the anatomy. Liver is unique in its ability to regenerate, already mentioned. Post-hepatectomy liver failures, incidence 2 to 10% normal liver and 10 to 30% in cirrhotic liver. Feature remnant records normal liver more than 30%, cholestatic more than 40%, cirrhotic more than 50% required. Liver volume assessment, that is right liver segment 5 to 8, 2/3 the total liver volume. Left liver segment 2, 3, 4, 1/3 of the total liver volume. Left lateral section, half of the left liver, that is or 16% of total liver volume. And how will you assess the this liver volume? Right liver, let's say I mentioned 2/3 of total liver volume, left 1/3. And this can be assessed by the help of the radiology department. How to extended liver resection, donor hepatectomy, right hepatectomy cirrhotic. This is the software is available. The departments, they will give correctly how much remnant or remain liver is there. So that is very important for the liver resection for the survival of the patient. Next is a hepatic function assessment. This is by the child Tarkot book score, the CTP score, or you can classify CTP A disease, B disease, and C disease. In my cases, all the cases were CTP A, that is ideal case for resection. There is no encephalitis, there was no ascites, bilirubin was normal, albumin is normal, prothrombin and second as normal. This is the ideal case for liver resection is that is Charcot classification score is 1. Others test for hepatic function. That is indocyanine green test. Indocyanine green retention value more than 15% at 15 minutes are considered more than 15 is abnormal. But sometimes in normal resected liver, you will get the abnormal value if the portal vein contains deposits or compression of the biliary radicals by the tumor. Then also you may get a higher value. And scintigraphy or technetium scintigraphy 99 gamma lacto human serum albumin also is available, but the indocyanine green is better than even PTC score. Biopsy, I already mentioned, not recommended. Only if you palliative treatments you can take biopsy. There is so many guidelines here. You can follow one of the guidelines. This is in cirrhotic background. The alpha petoprotein more than 200 nanogram per ml or one typical dynamic image you can treat as a hepatocellular carcinoma, or less than 200 with the 2 typical dynamics imaging technique, then also it is treated as a hepatocellular carcinoma. This is the background of cirrhosis. This is a very useful chart that the LIRADS, that's most important, definitely that LIRADS 5, definitely hepatocellular carcinoma, then multidisciplinary discussion for management consensus. And next LIRADS M is probably a definite malignant other than hepatocellular carcinoma. And 4 is tumor invasion to portal veins. So this chart is very useful for your resection. Or this is another chart for helping the deciding resection. You should always respect the liver, and future liver volume is low. Give respect to before the surgery. So you consider before all this investigation, and hand the liver with the utmost care. Cirrhotic with child poop class C and child poop class B with FLR less than 40 and comorbidities precluding or limiting the safe anesthesia. Comorbidities recent MI or severe COPD, then will be problem for it. Location of disease near major vascular or biliary structure that would preclude a margin negative resection. If you are low residual volume, then major liver resection can lead to inadequate future liver remnant volume and lead to a liver failure. If to increase the liver volume, you can achieve by portal vein embolization, or trans-arterial chemoembolization and staged hepatic resection. What is portal vein embolization? Embolization is portal vein on the site to be resected. Concept is atrophy and hypertrophy complex. That is one atrophy of the resection. Other side will be hypertrophy, where you are going to retain. Least hypertrophy of future liver remnant and allow major resection without post-operative liver failure. But don't wait for too much. 3 approaches for portal vein embolization: laparotomy through ileocholic vein, transhepatic ipsilateral approach, or transhepatic contralateral approach. Material used for these embolizations: gel form, fibrin glue, synthetic glue, polyvinyl alcohol, coils or iodized oil, absolute ethanol. And in case of right hemiliver, portal vein embolization regeneration rate is as follows: non-cirrhotic liver, 12 square centimeter per day at 2 weeks. 11 square centimeter per day at 4 weeks, 6 square per day at 32 days. Cirrhotic patient regeneration very slow. That is the pre-embolization picture. That's the post-embolization picture. This is the types of liver resection. That's it may be wedge resection, segmentectomy, left hepatectomy, that is segment 2, 3, 4. Right hepatectomy, that is segment 5, 6, 7, 8. And margin requirements, hepatocellular carcinoma 1 centimeter, cholangiocarcinoma also 1 centimeter, colorectal mets 1 millimeter, gallbladder 5 millimeter. There is already mentioned that adequate margin is enough, even though I mentioned like this. Generous exposure needed in open hepatectomy. Now the fashion is minimally invasive hepatectomies, both the laparoscopy as well as the robotic surgeries favoring the immediate recovery, etc. These various incisions, upper midline incision, Mikuchi incision, Merz-Benz incision, Cervilion incision, Roothoff. I am following Roothoff. You can advantage. You can right side. You can visualize the liver. If it is not amenable resection, you need not extend to the left side. That is advantage of Roothoff incision. This is one case post-operative picture of that is a ligate cystic duct. The common hepatic artery is going CBD, and this right hepatic artery, portal vein, etc. The our own patient. Intraoperative assessment, first hepatic first step is cholecystectomy. That should be inflow control, outflow control, and parenchymal pre-process section. Inflow, outflow, and parenchymal transection. Inflow control, that hilar dissection. Hilar dissection or cystic plate, 3 plate concept: cystic plate, hilar plate, and umbilical plate. And hepatic pedicle dissection, hilar plate versus extra hepatic glycerol pedicle. 2 approaches available. This is another picture, that is the hilar dissection, hepatic pedicle dissection, hilar plate versus extra hepatic glycerol pedicle dissection. This also, these you can see the right hepatic duct, left hepatic duct, this common hepatic cystic duct, and you should be gentle for the resection. Otherwise, you may at any time land even travel by bleed in the portal vein, etc. So there will be inflow control from the hilar plate dissection, and this another technique involved on this Lennox capsule dissection, the intracapsular dissection. This is a left picture. This is the hilar dissection. Infravascular occlusion Pringle maneuver. That is we already mentioned yesterday. Trauma. There is a 3P: packing, pressure, and Pringle maneuver. Pringle maneuver you can control by your finger, the fingers, or the DeBakey or bulldog clamp, and it was oldest and simple way until pulse in hepatic artery disappears. This mentioned in 1909. That is Pringle. Oldest hepatoduodenal ligament encircled with a tape. My picture was tape or this DeBakey clamp. It should be gentle until pulse disappears. None of these my liver resection never use this Pringle maneuver because it may mislead, because bleeding, no bleeding, we may consider no bleeding. Actually, need not apply splint. In trauma, it is applied. In the surgery, not much use. Let's say inflow vascular occlusion, continuous Pringle, intermittent Pringle, ischemic preconditioning. That is up to 60 minutes in normal liver. You can normothermic condition, you occlude the this hilum. Up to 30 minutes in pathologic liver in cirrhotics. Maximum time should be 120 minutes. And intermittent Pringle also advised, and the ischemic preconditioning. That is intermittent is 50 to 20 minutes clamping and 5 minutes unclamping. So during the 15-20 minutes you can dissect, then stop dissection, again clamp. Like this, clamping and reclamping. And ischemic preconditioning, endogenous cell-protective mechanism hypothesis there. 10 minutes of ischemia followed by 10 minutes of reperfusion. Protection against the subsequent transaction with the complete inflow. That is the theory behind it. This is one example of half Pringle, not a typical Pringle manor. That is interrupt the arterial portal flow selectively one lobe. This in this condition. Avoid ischemia in the remnant liver. Advantage. Avoids planktonic congestion and clear demarcation of the resection margins. This is outflow control. That is IVC is controlled. Complete mobilization of the liver is required for this clamping IVC. Clamping the intrahepatic IVC and suprahepatic AVC. That you can full control, but there is chance for ischemia of the liver. And modern techniques, liver surgery is no much problem because no bleeding technique. That KUSA, modern instruments available, harmonics focus, ligature, vascular staplers, water jet, Habib probe, etc. And my dissection was not much this KUSA etc. is not available. Only most of them my digitoclasia. You mark the liver with a cautery and you can crush the liver with your index and thumb finger. Then the biliary radicals vein artery with your fingers. You can ligate either side. So very easy. You ligate. You can also use this harmonic ligature available. So combined procedure, and you can practice this in your own home by purchasing a god liver. I think that is ideal. You can do a cholecystectomy in your kitchen, and you can do the finger fracture, and nobody will no bleeding. So if you contact your front, and during the before my liver resection, I resected bodies in the forensic with the help of forensic department. 2 or 3 bodies inside the body and on the table, so you can easily identify your middle hepatic vein and this candy line, etc. And so friends, you can visit your forensic department. They are always ready to help if you are interested in liver anatomy. This is the crush and clamp finger fracture technique and ligations. Cavitron ultrasonic surgical aspirated. That is, the instrument is available in our surgical gas department, Calicut. Pencil grip surgical hand piece contains a transduced oscillation longitudinally at 23 kilohertz. That is the basic science KUSA. And this pencil grip surgical hand piece contains transducer oscillating longitudinally at 23 hertz. So this the picture is there. And exposure of cells with high water content and fragmentation of parenchyma and sparing the blood vessels and bells. Very easy, without any drop of blood loss, you could resect the liver nowadays with the help of this KUSA. This constant water irrigation cools the titanium tube, washes the blood about the KUSA. Suction tip are inbuilt with this, and it less post-operative operative time required for this KUSA. And this is our favorite instrument, the harmonic scalp. Ultrasound activated shear cause protein denaturation. Ultrasound generator, foot switch and handpiece, and there's a vibration. This bipolar vessel sealer. These are the instruments for the liver sections. Liver tissue crushed between the blades and coagulation seal vessels and seal off vessel up to 7 mm, no bile leak. Vascular staplers also available. You can easily identify the bile by simple technique. You take a cotton swab, soaked with saline and keep it there for 5 minutes. Next, you remove it, you will see the yellowish color. Then you can apply cautery or just put a ligature. That's enough with the simple technique. Or some people do the cholecystectomy duct, you cannulate and saline injection and press from below. But this is a negative system, you are making a positive is also not ideal. Inflow and outflow, vessel control mentioned, parenchymal transaction, reduce the operation time. Use when in trouble this instrument. This is the now already Madhumali mentioned that RFA. This is only superficial tumor, less than 2 centimeter and deep 2 cm deep to skin also. And for most of the for a palliative surgery or less than 2 centimeter, you can radio frequency ablation. You could use this. Bloodless liver surgery, radio frequency I mentioned. This is a water jet, a picture of water jet, and this also bloodless operations possible using this. The individual knife, the pressure generating pump connected to a handpiece, that's a mechanism. Just jet nozzle with a pinhole projects a physiological saline and suction line connected to the trapped hole of separate ducts and blood vessels from the parenchyma. This is a new instrument. I don't know whether it's available in other institutions. Water jets. Anyway, it is very useful instrument. If preoperative, well assessed, intraoperatively, meticulous, managed, complications are very, very less. This is a left liver bed after right hepatectomy. Complications of liver resection, most important is the blood loss. We are not careful. And poor technique, bile leak, postoperative liver failure, very important problem we have to face. We are not aware about their future liver volume. And if liver remnant is inadequate, another is pulmonary complications and DVT, etc. Bile leak, definition of liver failure. This is liver bile leak by bilirubin concentration in drainage fluid at least 3 times 3 serum bilirubin on or after 3rd postoperative. And need for radiological or operative intervention resulting from biliary collection or bile peritonitis if it is there's a bile leak. Liver failure. Post-hepatic liver failure is inability to maintain its synthetic secretory detoxifying functions, presenting an increased INR and hyperbilirubinemia on or after 5th postoperative day. Most severe complications with mortality as high as 70% may be possible if you are not careful. If preoperative, well assessed, intraoperatively, meticulous managed, complications are very, very less. But the patient possibly managed intensive care unit, hemodynamic parameters should be checked. Glycemia control should, patient go for hypoglycemia, so your adequate feeding should allow immediately after operation. Another complication that most of them ignored by hypothermia, coagulation parameters, electrolytes, especially hypophosphatemia. This is one of my first case. His name is Chemban. This is from Chembuad near Tusharagiri. This is a tribal patient. He is admitted actually in a S1 casualty and they discharged the next day thinking that it is acid reflux disease. And the 6 actually again admitted with the features of guarding and ultrasound show hemoperitoneume. In Oriental countries, one presentation is catastrophic presentation, sudden rupture of the liver and death in the hepatocellular carcinoma. This is a rupture, and this MRI shows a huge right lesion, well demarcated. This is our portal vein. He is discharged without any problem and survived for 2 years. This is the second patient, Balakrishnan. He was from Palakkad. Another is again right hepatectomy done for this patient. This is another patient, he recently died 2 months back, Pathumani. She operated on 2015, that February 10th, and died this March, last March 28th. Very close to me, this patient. Any problem, they always contact me. They survived for 8 years. Right hepatocellular carcinoma, right hepatectomy. This is my rooftop incision. This is that patient, first patient, Chamban. And now this modified Makuichi incision also. And these are my, you are searching for looking for your line of cannuli and gallbladder. You are going to, this other picture is the beautiful sign. When the clamps, bulldog clamps, you wait for 5 or 10 minutes. Gradually you could see the beautiful sign. That is very beautiful to see this sign. The liver is turning to blue. Wait for some times. So you can go for this line of demarcation or right hepatectomy. That is left lobe lesion. This is another secondary wedge resection. See a gallbladder colon infiltration. Then another hemangioma eroding the colon. This is I am going to starting the cholecystectomy. This is a gallbladder, and first step is cholecystectomy, and dividing. And this is a supra hepatic area. That is the infradiaphragmatic. This is the IVC, and this is the IVC blue color. This is the right hepatic vein. This is the liver. This is a supra hepatic dissection. Hilar dissection. This is also my this is the portal vein, right branch, left branch, and this is the cystic duct, the common hepatic duct. I usually ligating the portal vein 6-proline, and very easy to tackle the portal vein, but very difficult to tackle the this CBD, common hepatic duct, because which in the capsular fibrous capsule. This is another picture of another patient, right portal vein, it's left portal vein. This is the last picture. I am going to marking the line of candeli and going to this is the last step, right hepatotomy, the vein is removing. This is left liver bed. This is left. You can, if there is a bleed, you can press the remaining liver. Any bleeding, you will keep a gauze, yellow color. You can call it. Or bleeding is there, gel form. You can apply gel form here. No much bleeding. There is no. Better to avoid. You can produce a secondary infection, gel form, etc. This is a radical cholecystectomy. Then post hepatic right with the right hemicolectomy, the infiltrating into the colon also. This is the picture with the colon secondary. This is hepatocolectomy with the gallbladder. This is the colon is there and gallbladder part of liver. Another is there is a terminilium, transverse colon, the tumor, hemangioma. This is my overall experience. So the right hepatectomy, total number 15. Hepatocellular carcinoma is 13. Left hepatocellular 1, metas 1. That first case sarcoma, radical cholecystectomy 2. Hepatocolectomy, CA gallbladder 1, hemangioma 1. Non-antidiabetic wedge resection 7, and 1 intrahepatic pregnancy. Mortality is only, the number is showed only one mortality. It was a post myocardial infarction. That is the night patient developed myocardial infarction and death. There is one death. No major morbidity. Yes, that's all about my journey with the liver. Thank you for your patient hearing.
Thank you, sir. May I request you to kindly be seated? Professor E.V. Gopi, sir. And may I please invite all the dignitaries back onto the dais. Chairman ASI Kerala Chapter, Dr. Srijian, Dr. Muhammad Ismail, Dr. Rajan, Secretary, ASI Dr. Madhu Murli, Treasurer, Dr. Zulfikar, and Dr. Santosh John Abraham also. We have the awarding of the citation and the certificate to our honorable orator. All the PG participants for the e-poster competitions kindly report to the conference hall ASAP, please. The revised list of the students selected for the lunch with the teachers is on display on the TV screen. Please make note. We kindly like to remind all the PGs to check the list and report it to the terrace adjacent to the hall at lunchtime. All the delegates, faculty and PGs are requested to sign the TCMC credit hour forms for both the days of the conferences by lunchtime. This is very crucial for issuing of the certificates, and the forms have been kept at the back of this hall for the convenience of all the delegates and the PGs. Kindly make sure that you do this. It is essential for issuing the certificates. We have the video presentation session next, and may I please invite onto the dais Dr. Sijin, Dr. Alfie Kavalakade, and Dr. Bipin, please. 3 chairpersons for this session. The first presentation will be made by Dr. Sharath Krishnan, surgical oncologist, GMC Thrissur.
Yes. Please, yes. Dr. Sharath, please.
Good afternoon to all. At the outset, let me thank office bearers of ASI Kerala chapter, Srijan sir, Madhu sir, and Sulfikar sir, and the organizing team of Rounds 2023 for sharing this, allowing me to share this platform with you. Our the presentation, greetings and regards from Government Medical College, Thrissur, Department of Surgical Oncology and General Surgery. Here I am presenting a case of a 43-year-old female who has presented video presentation. She has presented with swelling in the parotid region of 3 years duration of firm consistency swelling, and it was gradually increased in size, no facial involvement or no deep lobe involvement by the tumor on MRI. The pathologist have reported it as a pleomorphic adenoma. These are the MRI pictures. The swelling is confined to the deep lobe, the superficial lobe on the lower pole. For the benefit of the postgraduates, we know the first 2 parts of the surgery, superficial and total conservative. What is radical? We remove the adjacent structures. That also is understood. What is less understood is adequate parotidectomy, where you remove only a removed parotid tissue, especially in a Warthin's tumor or a very well differentiated tumor located to the poles of the parotid. The correct anatomy of the facial nerve is very important, especially for a beginner. Ideally, for a beginner, it should be surface marked properly, so that the exit of the nerve at the periphery can be well identified. The point is, we may preserve the nerve at its trunk, we may preserve the nerve at its branches, but finally, if it is already injured at the periphery of the nerve, it may cause problems. So the position is extended neck position with head turned to the opposite side. We are comfortable draping the patient with a double towel under the neck. Some people find it difficult. And the point to be taken care here is we have to expose the angle of the mouth and the canthus of the outer canthus of the eye properly to see for any possible injuries. The incisions that can be preferred is an over the tragal cartilage incision, also called the facelift incision, especially in a very young female. And this produces less of cosmetic disfigurement. And this is a classical modified Blair's incision, which is usually preferred by the beginning surgeons. So the importance of this incision is the angulation should not be acute, especially around when it's curved around the lower part of the gland and also on posteriorly in the mastoid region. We had this tumor in the lower pole, so we could comfortably place this incision. The extension of the incision can be made into the upper neck crease, which is very well visible. In a female patient, we make use of the pierced ear lobule for a proper traction, but care must be taken to clean that area properly to avoid infections. So we have put a classical Baer's, modified Baer's incision or the Lacey's incision in this patient. The incision, some people use lignocaine with adrenaline to produce less of bleeding there, but if you have a comfortable anesthetist who can give you hypotensive anesthesia, it should be good enough. You can proceed without much of a problem. Here the incision, you can very well see that upper neck crease traversing across. We have kept short the incision because there was no neck node involvement and FNAC was reported as a benign disease. So slowly we are raising the flaps. The tumor on an MRI was not showing any involvement of the skin or subcutaneous plane. So then also we had kept a little bit of platysma, complete platysma over that area onto the tumor. We have dissected that area, we have only the skin there. The hooks help in the initial part of the dissection, but as we proceed anteriorly, dissection is it's more of helpful to have a retractor, especially a small one. So that is the anterior dissection being done. Care should be taken. We are using this monopolar cautery device at a very low setting. Coagulation is kept at a very low value. You can very well see that platysma which is over the tumor on that area. The slow dissection of that area is being done. We should have a rough idea of how much the anterior end of the gland is. We have to palpate that area carefully so that when we reach the anterior end of the gland, we slowly shift over from cautery dissection to scissor-based dissection. The point here is when we have dissection with cautery, even though if you have the not found the nerve, there might be a thermal injury. Scissors, if you use the thermal part of the injury, will be very, very less. So that is the anterior most end of the gland. I have palpated the gland there at the anterior most part, and the dissection is almost complete there at this point of time. So regarding the next part of the dissection, the gland posterior dissection of the parotid tissue between the tragus and down into the mastoid area is the next part of the dissection. Here we have the tumor in the lower pole. Since it was benign, we didn't go for a gross margin in that area, but unfortunately the greater auricular nerve was coming close to the tumor. We couldn't preserve that now. We started off the dissection by tracing the anterior border of sternomastoid and posterior border of the digastric muscle. That is the digastric area that we are dissecting, and with the tumor just below that one. The muscle, the greater auricular nerve is still seen, the tumor with the platysma over it, and the posterior belly of digastric. So there are various methods of identification of facial nerve practiced by different surgeons practice different methods. The point here is we need to be consistent with whatever methods we are using. So what we use is a combination of two methods. We identify the tragal cartilage pointer from above. You start dissecting from above, identify the tragal cartilage pointer, and from below the insertion of posterior belly of digastric. So you can go for the dissection in this area at any depth without much of an issue, unless the tumor is located in the deep part of the lobe close to the nerve exits. It can be deceiving at times when you have a tumor at this area. You can shift the nerve in either directions and cause injury to the nerve. So that when we start dissecting this area, unfortunately, for especially the beginners, we use it, every strand that crosses this area from posterior to anterior, you feel like it's a nerve. And if you're unfortunate enough, there will be bleeding from the vessel there, spoiling the entire field. So we have almost completed the upper part of the dissection from the tragal, upper end of the tragus, and that is the tragal cartilage pointer being just visible now. The tragal cartilage pointer is the end of the tragal cartilage where the bony external artery canal starts forming. Here we have almost dissected that area. What's shown is the tragal cartilage tragal cartilage pointer and the posterior belly digastric insertion. We are expecting the nerve in that area. Without much of a difficulty, we could identify the nerve in that area. That is the trunk of the facial nerve that is being shown there. The facial nerve trunk is seen exiting at this area close to, that's usually at 1 centimeter below the Conley's pointer or 1 centimeter above the digastric insertion at somewhat that depth. So usually there are no confusions of identifying the trunk of the facial nerve, but when the tumor is located deep or in close proximity to the nerve, you may have a difficulty. Next decision is to where to dissect, whether the upper pole or the lower part of the parotid. So we prefer, especially in this patient, she has a tumor in the lower pole of the parotid. We prefer to dissect in the upper pole area because the margins are, we are not worried about margins there. And the second thing is, we are not worried about the margins. Second thing is, the tumor is located towards the lower pole. Second thing is, the dissection in this area, the ophthalmic branch of the facial nerve is what is most important as far as the dissection is concerned. So we are carefully removing all those glandular, we have identified the zygomatico-temporal division there, and all glandular tissue posterior to that nerve is removed at this juncture. Careful dissection and especially the uppermost area has to be done because when we cause morbidity in parotid surgery, the ophthalmic morbidity is the most dreaded ones because they end up in exposure keratitis and all sorts of problems, and losing a vision is the most dreaded complication you can create. So that is the upper pole of the gland that is being dissected out. The lower part of the gland, after the identification of the muscle, so that is a complete dissection of the upper part of the trunk of the facial nerve with both branches carefully displayed. What is now, we will proceed with dissection of the tissue in between. Here we are removing both the superficial and deep part of the lobe of the parotid simultaneously because there is nothing much to be taken out at the anterior part of the gland between the superficial and deep lobe. Carefully, we are now visualizing the retromandibular vein also there. We can see two trunks arising from the lower trunk, which are the buccal branches, and the tissue in between is dissected carefully. Compared to the size of the nerve proximally, these buccal branches are little slender, and utmost care and patience need to be there to dissect these branches because a small traction, especially towards distalmost part of the dissection, will cause injury to the nerves. So that completes the dissection of the glandular tissue in between the upper and the lower trunk. Now what is left over is the tumor part. Now why we come over to this part last is because nerves may be involved in this part of the gland. So if we keep the other areas which are uninvolved by the nerve to the last part of the dissection, you may lose patience and there is high chance that you may injure a normal nerve. So that's why this part of the dissection was kept to the last, and we could successfully complete the dissection of the deep lobe. This is the trunk and all its branches displayed. The zygomatico-temporal and cervicofacial, the retromandibular vein and the artery is seen in the depth. Due to lack of time, we have not included the deep part of the dissection in the, it's also completed. all those in relation to the deep part of the nerve was also removed. So that is a display of all the nerves and its branches. All the nerves were preserved. There's almost complete hemostasis was also attained. This is the final dissection picture that we have. We usually, while closure, we usually keep a gelatin sponge to avoid, 2 to 3 reasons are there. One is it avoids undue traction on the nerve by the drains. It helps in, at the time of removal of the drainage also. Some amount of auricular nerve syndromes also will be lesser in this thing. We use a Romovac suction drain F12, or you are even comfortable with a Minivac drain. The skin closure is usually with the 4O sutures, and we have used tissue glue for tissue approximation here. So those are the final things. So methacrylate, butyl methacrylate tissue glue was used to close the skin. So that completes the surgical procedure. This is how we use the dressings. This is the post-operative day 3 picture after removal of the drain. And this is our surgical team at Government Medical College Thrissur, Department of Surgical Oncology and Department of General Surgery. All these people were involved in this one, in this video making. I have special mention Dr. Sumen, who has taken all pains to edit this video. Thank you for your patience.
Dr. Sharath, that was a very fantastic display of your surgical field. And will you prefer any pre-operative evaluation of patient nerve with any investigative modalities?
Not a routine thing, because we don't even have an intraoperative nerve monitor. So that will be beyond our thing to nerve conduction study. That's what you mean. Or just evaluation of the nerve regarding
Any investigative modality like an MRI or something?
MRI was already done.
Is it possible to evaluate the patient nerve with an MRI?
When the tumor is so close to the nerve, and you mean the function of the nerve with an MRI?
Any infiltration?
Definitely in patients who have the disease which is close to the nerve trunks, it will help. And to also to see whether any nerves are infiltrated, it will definitely help. In this case, it was not. It was in the lower pole, and we couldn't find any problem.
What's your strategy in resecting the nerve in infiltration?
The surgical oncologists play this thing, so we don't look. We reconstruct sometimes if you have the people around to reconstruct. Otherwise, we will go ahead with the resection of the nerve. It's it's a very morbid thing. We are used to doing, actually when this case was given to me for presentation, we did have only radical procedures. Luckily, Ravindran sir had given me this case, so we could do it. So most of them are radical procedures, and we find it very morbid, and we resect everything, all structures all around that area. It's a really morbid surgery. You find yourself in a difficult situation when you see them post-op.
Any questions from the audience? One question. So, in this case, the FNAC was pleomorphic.
Fine, which you want to know?
No, my question is, if there is a histological surprise, will you, if you have done an adequate parodontectomy, when will you go for a second surgery or relook surgery? The time gap?
Here, most of the time, we go ahead with total conservative parodontectomy. It all depends upon the patience of the surgeon most of the time. Doing a total conservative and a superficial, morbidity-wise, if you are patient enough, it doesn't matter. Doing a second surgery over an already dissected area is very difficult, even for the expert surgeon. So, unfortunately, this patient has come as a low-grade mucoepidermal carcinoma, but margins are okay. But we have to add adjuvant RT.
My question is, if somebody goes for a second surgery, is there an ideal time gap?
Gap 6 weeks, 6 to 8 weeks.
Thank you very much. Thank you.
Thank you,
sir.
sir.
May I request the chairpersons to kindly hand over a certificate to our esteemed speaker. Thank you, Dr. Sharath. May I invite Dr. Binny John next, Professor GMC Idukki.
Let me thank ASI Kerala Chapter Executive Committee and the organizing team led by Professor Jose Gamaliel for allowing me to present the top video here. Let me go ahead with the video straight away. This is a straightforward case of varicose vein, a lady who presented with chronic venous insufficiency and dermatitis changes. So this the patient is positioned supine and incision is placed exactly in the groin crease. Normally you expect an incision below the groin crease, but that is not correct. Our standard concept is 4 centimeter below and lateral to pubic tubercle. That has been now changed. It's only 2 centimeter below and lateral to pubic tubercle. The recent Bailey also has changed the previous concept which is there in most of the anatomy books. So the incision is at the groin crease. So you cut the skin subcutaneous tissue and you leave a membranous layer of superficial fascia. Just underneath that you will expect the vein to be there. So the vein, there's a periadventitious layer which is picked up and cut, and in this case there was an accessory saphenous vein that is seen, that is a lateral thigh tributary which is actually joining the common femoral vein, and the main trunk is joining the side of the accessory saphenous vein. You can see both veins there. So the accessory saphenous vein is important, especially in case of long saphenous vein surgery. That has to be decided and detected before surgery with a Doppler, and ideally with a preoperative Doppler you have to mark the accessory saphenous vein, because this is one culprit which causes recurrence if it is not dealt properly. So especially after the advent of thermal ablation techniques, in all those thermal ablation techniques, the maximum recurrence occurs with improper handling of accessory saphenous vein. So your radiologist has reported correctly and you have to tackle it correctly. So I'm now going with all those branches. So the circumflex iliac, superficial circumflex iliac is that one, and the other one is the superficial inferior epigastric, what is being dissected now. All those branches has to be carefully, tributaries actually has to be carefully dealt with. Then you have to go for one external pudendal vein that is coming from medial. That's the third tributary actually coming in that vicinity. So if we catch all these tributaries and you actually loop it before actually you go for ligation. So it's just all these three are looped for demonstration only, otherwise you can go one by one. So there's a second inferior epigastric, and go for the third, that is the external pudendal. So once you do all these three, you can go for a ligation of all the three branches. Actually, you should go for the dissection inside the perivenous fascia, between the adventitia and the perivenous fascia. All the vein and its tributary should be dissected in that plane. So that is, all these branches are being ligated. So the patient side, ideally you may actually do bipolar diathermy also. That may be adequate, but for a demonstration we have gone for a ligation of all those tributaries. there are two more tributaries actually, posteromedian and anterolateral. So posteromedian is actually not seen in this case. Anterolateral is actually coming as accessory saphenous vein and ending in the common femoral vein in this situation. And the main trunk of saphenous vein is joining the accessory vein. So now you can go for catching the accessory vein at the lower end of the incision, go for it and dissect it upwards until you reach the common femoral vein. So that is cut. And most of the time carefully that periadventitia can be peeled off. Some minor tributaries may come in between which you may have to tackle till you reach the common femoral vein. So that is the point where we have reached the common femoral vein. If you look at carefully, that common femoral vein was shown in that dissection. Now we are going to the main trunk, which is actually joining the lateral part, medial part of the accessory vein, and both together ending in the common femoral vein. That is the main trunk. That is actually almost 1 centimeter in size because of the good reflex in this case. So actually, as the reflex increases, the size of the femoral long saphenous vein also will increase. So in a preoperative Doppler, it is always important to record the size of the femoral long saphenous vein in the just before the pre-terminal valve area. You have to measure the size because it has an implication in the management decision. So the two veins, accessory and the main saphenous vein, has been dissected up to common femoral vein. And just for demonstration, so the accessory saphenous vein now is being ligated. It's close to the, that's a tributary actually coming, joining posterior to the great saphenous vein. And the dissection is continued up to the point where it ends in the common femoral vein. Okay, now for a demonstration, we are trying to dissect one more tributary there, I think, right? Okay, that is one more tributary there. So that is the end of ligation of all the tributaries. This is for demonstration. There is a reflex from through the main trunk is being demonstrated. This sign is called Turner-Warwick sign, where intraoperative Trendelenburg test you can call it. Now you ligate the vein close to the common femoral vein. That is called flush ligation, without actually narrowing the common femoral vein. Okay, so you go for that. Then the next is to tackle the accessory saphenous vein. Actually, when accessory saphenous vein is there, it is not good idea to leave it as such there because it can lead to neovascularization and recurrence. So do a sclerotherapy in a retrograde way. So the form sclero is injected into the accessory saphenous vein, and you slowly inject and pull the, this is an infant feeding tube actually, number 4 size, is slowly withdrawn till the form appears, and you just ligate and finish it. So it will undergo a chemical ablation after the form sclerotherapy. Now you go for the main trunk. A stripper is a disposable stripper is introduced in a retrograde manner. 80% to 90% times, so it will go retrogradely because most of the valves would have been incompetent by the reflex. And you can see the tip of the stripper reaching the leg area. Once it reaches the leg area, you can just ligate that with a vicryl there and open the leg area and retrieve the stripper from there. So once the stripper is retrieved, pull it down and put the olive head at the proximal end. So that olive head is put, and you just pull the stripper down and ligate at the proximal end. Okay, once that is done, we can close the groin incision after applying the stripper, and the stripping is always done in a retrograde fashion, because it will invert the stripper into the inside of the vein. If you are using a small olive head, you actually go for an inversion stripping. If you select the smallest olive head, because the big vein, it will invert inside, so that surrounding tissue damage will be minimum. If you use the big stripper head, it may not actually get inverted. So that actually I have cut short the video just after that. There was not much of significant perforators in the leg, and we went for foam sclerotherapy of the leg veins. So multiple injections of foam under ultrasound guidance is given, 2 to 3 ml at multiple sites in the leg veins. That is enough to tackle the varicosities in the leg. And thank you very much, our house surgeons at Idiki Medical College. Thank you very much for kind listening.
Sir, that was a very fantastic demonstration of events. Actually, there are a few situations where you find a lot of perforate incompetence below, and there is no saphenofemoral junction incompetence. What will be your plan?
If any of varicose veins is defined only if there is a source of reflex with more than 3 millimeter size of the vein. So our aim is to treat the reflexing points. So perforator should be ligated. Okay, if we go for open surgery, and next is the cosmetic component, that is a tortuous vein. That can most of the time treated with foam sclerotherapy. Saphenofemoral junction is not incompetent, need not treat saphenofemoral junction because the reflexing point is different.
Do you have any complications of foam sclerotherapy while doing under a spine anesthesia? So
we had no major complication per se to say that we had a complication. But we had a study where we did almost 40 cases where the Trendelenburg procedure was done under local. The entire remaining veins were treated with foam sclerotherapy. So out of that 40 cases, we had almost 4 cases having minor DVT, because all cases were followed up with sequential Dopplers after. So immediately 1 week before discharge, 1 Doppler, then patients called at 3 weeks, then at I think 6 weeks, something like that. So some years back it was done. So we had 4 cases out of that 40 cases, minor DVT detected. Then all those cases were treated with anticoagulants. Now our policy is, after this experience, what I do is I give Rivaxa to all these patients for 3 weeks, prophylactic dose.
Sir, again, what's your plan in a chronic DVT along with varicose veins?
If the chronic DVT is there, definitely don't go for superficial vein surgery first. So identify which segment is thrombosed. It is a limited segment, especially iliac vein, that is amenable to vein stenting. So send to a vascular surgeon or an interventional radiologist for a vein stent, that's a wall stent which is put. Once that outflow is corrected, then you reassess with the Doppler, and there is a reflex anywhere that has to be corrected with superficial vein surgery. That will be a best approach. But this has to be done under anticoagulant cover, because some of these patients may be thrombophilic and may go for recurrent DVT.
Any more questions, sir?
What is the direction of the stripping you are mentioning about?
This
the
above downwards.
Any
Above downwards.
reason, particular reason?
One reason is the groin wound is close before stripping. So there is no chance of a hematoma or collection in the groin wound when you strip from above downwards. Second is if you use a olive head, small olive head, the bigger size of the vein is in the upper part. The olive head will get inverted into the vein and we can go for an inversion stripping. Actually, inversion stripping is better than the other type of stripping because surrounding tissue damage will be less. The lymphatic and other damages will be less.
Any more questions? If not, thank you, Dr. Benny, for the
Thank you
nice
very much.
presentation.
Thank you.
May I request Dr. Benny to kindly remain on the dais. We have a certificate presentation. May I request the chairpersons to kindly do the honors, please. Gentle reminder to all the delegates and faculty and PG members, you're kindly requested to sign the TCMC credit hour forms for both the days of the conference by lunchtime. This is essential for issuing the certificates. The form has been kept at the back end of the hall for convenience. We have a lost and found key here. If anyone has lost a key to your cars, please approach our desk. Thank you. Move on. The next presenter, Dr. Prakash, gastrosurgeon, Aster Medcity, Cochin.
At the outset, let me thank ASI Kerala chapter, Dr. Siddiq and team for this opportunity. Since this is an annual PGCME, I'll just touch upon the basics of anastomosis because it's a very basic topic before going into the video part. So this, I'm sure that almost all the teachers would have emphasized time and again before anastomosis. So these are the basic points before making anastomosis. We should be very careful about all these points. Each and every point is important about vascularity, lack of tension. There should be good approximation. There should be no distal obstruction, no hematoma, careful tissue handling, and overall the hemodynamic stability of the patient. And these are the points which are for and against healing of an anastomosis, which we should be careful about. We should try to correct whichever points which are amenable for correction if it is an elective surgery. So that, for example, if the glycemic control is not good, we should try to correct that. If the patient is smoking, we should try to correct that. If the albumin levels are low, we should try to correct that. And some non-manageable conditions, we like to take it as a high risk, like age of the patient. And so essentially we should be careful about the technique, which where is the area where we can have an impact upon the healing of the anastomosis, then good blood supply and no tension. And another important area is about usage of clamps. If possible, we try to avoid clamps at all the anastomosis unless it's a loaded bowel, and try to minimize the use of clamps. If at all using, don't avoid pressure or too much closure on the clamp. So to come about the various type of anastomosis, it could be made as single layer or two layer, or you can make it extramucosal or full thickness, and could be interrupted or continuous, or you can make in many designs like end to end, side to side, or any combination, and hand sewn or stapler. To put it in a nutshell, if you make any of these choices, the results are not going to be not much different. Meaning that if it is single layer versus two layer, or if it's making continuous versus interrupted, there are some advantages or disadvantages, but in terms of leak or in terms of long-term results, in terms of overall results, they all remain same. So we should master one technique which you are comfortable with and try to stick on that, and that's the best method of doing it. So just to have a comparison about the continuous and interrupted, we all know these techniques very well. So if you are making an interrupted anastomosis, we are trying to approximate the tissues closely together. But in a two-layered, we try to slightly invert the tissues for better hemostasis and for better approximation in the inside. So these are the two basic techniques. In interrupted, you have to make all the switches interrupted. Very often surgeons tend to avoid the mucosa. So the switches pass through full thickness except the mucosal part. So it will be passing mostly through the submucosa and do it. This will theoretically improve the blood supply to the curtains. This will be better for inflamed bowels. This will be better for if you have luminal disparity, or in terms of difficult bowel, this may be a preferred method. But if it is a continuous anastomosis, the time taken is less and the anastomosis is good. Again, here you should be careful about approximating it too tightly, or you should not have any persisting effect on the bowel. So these are again the basic types. So generally these anastomosis are preferred where the access is not easy, like G-junction anastomosis, low anterior section, or if there is disparity. Typically in a patient with the Crohn's bowel where we have luminal disparity, the bowel wall thicknesses are different. Interrupted may be better than continuous. And these are different designs which you are all familiar with. And different suture techniques. Nowadays it's not that common to use these type of Cornells or Cushings, which is basically good approximation sutures, which some surgeons continuously use it. They are full thickness approximation, avoiding the mucosa in a horizontal matter sutures. Cushing is a modified version where we include less of the full thickness. It's more of a neuromuscular type of sutures. Or there are sutures, technique like Gambi sutures, where you have a mucosa approximation is carefully taken in a specially designed suturing technique, which you can see on the suture, which theoretically has a better approximation and a good approximation of all the layers. And the inverted Lambert sutures are also very popular. It's mainly for interrupted small bowel anastomosis. So this is a single layer interrupted. So we'll just go through the video clips of each of these. So this small bowel anastomosis using interrupted anastomosis. Here the surgeon is mainly focusing upon interrupted sutures. This three of silk sutures being used. So as I said, it's better to start from the middle of the anastomosis and then you can go to the ends, and so that your lumen approximation will be better. And if you are doubtful about the lumen disparity, you can tag the sutures and tie at the end, because in interrupted anastomosis, if you tie and come to one end, the last end becomes less precise, so you can tag that and the suture that at the end. So basically you come out of the seromuscular layer and then come to these submucosal layers and complete the anastomosis. And this is a continuous anastomosis. This again a ileocecal Crohn's patient. So you can see the cecum or the proximal ascending colon slightly bigger and thickened and inflamed, and the ileum is supple. So this is a continuous type of anastomosis. These are basic anastomotic techniques. So first layer you make with non-absorbable suture, preferably with polypropylene sutures, continuous. I would suggest to take the seromuscular sutures always slightly longer than the axial lumen, so that the ends of the anastomosis supported, so that there is no acute kink at the entry point or the exit point, so that the lumen always remain open. Particularly, this is important in anastomosis like anterior gastrogenostomy, because the angulation of the small bowel at the front limb is very common and can cause delayed recovery for the patient. After that, you make an enterotomy, which is slightly smaller than the seromuscular layers, and then this classical full thickness continuous anastomosis. So the next layer comes in as in the corner. You can take a U-shaped sutures on either side, and then you can come in and do full thickness sutures. But again, while handling the tissues, we should be careful about not to handle the full thickness, preferably catch hold of the seromuscular layer and do the anastomosis. It's better not to handle the mucosal part as much as possible. So tissue handling and tissue anastomosis should be careful about, rather than crushing or traumatizing the tissues. And as far as try to avoid hematomas, if at all hematomas are there, give pressure, wait, and then continue the procedure. So once this layer is completed, you can come to the anterior layer. In the corners, either you can take a cornal suture or you can take a U-shaped suture and come back anteriorly. While taking the anterior sutures, we should be careful about not everting the mucosa, because that happens mostly in the anterior layer. So here it's better to take less of mucosa and more of seromuscular sutures. And finally, the polypropylene fourth layer can be taken. Coming to the laparoscopic side-to-side suture, this is an intracorporeal anastomosis after hemicolectomy. So the ileum is being stapled. And then you have the colon, which is devascularized, and then you can divide the colon. And then the ileum and colon are tagged together, because since we are putting an intracorporeal stapler, it's better to support the bowel with 2-3 seromuscular sutures, so that while you put the staples, it doesn't get disengaged or it should not perforate through the ends. And then you can make an end. So at least 3 sutures we should take, and then continue with the enterotomy, and then a stapler is being passed, and you can make an stapled side-to-side type of anastomosis. So that's a completed anastomosis. And finally, the colorectal anastomosis. It's a colon to rectum anastomosis. So this, skip this part. So the last part of TME is being done and the rectum is being tapered. And finally, you transfer the rectum from the suprapubic stapler. That is a stapler coming from the suprapubic level. Linear staples are available which can transfer the bowels without any trauma. And finally, you make a small incision and bring the specimen out to do end-to-end color and end-to-side colorectal anastomosis. I think we can proceed with the discussion. The time is over.
Excellent videos, Dr. Prakash. One query, when you do a side-to-side anastomosis, especially in lab colonic anastomosis, any special precautions to avoid a blind pouch syndrome, or have you had any issues like that when you do a side-to-side?
Yeah, that's a very important point, because here what we do is to predefine the length of the staple. That's one. So you like to make supporting sutures which are 2 to 3 centimeters extra. So that first suture should start from the blind end at least 1 centimeter and go up to the, suppose you are taking a 60 mm stapler, you make around 8 centimeter wide supramuscular supporting sutures so that your staple remains within that limit, so that your blind on either side is avoided. It's a rough way of doing it. There is no absolute hard and fast rules there.
Sir, you are doing a lot of robotic coronary resections. So what will be your strategy in an anastomosis? Either it's a hand-sewn anastomosis, intracorporeal hand-sewn, or a stapler?
Actually, there are very much options, various options in robotic surgery when it comes to, suppose it's a high anterior resection, you can deliver the specimen through the open rectal stem after, of course, cleaning it with betadine and clearing that. Then you can put a purse string onto the, because robotic suturing is not difficult, purse string onto the upper rectum, and then you can bring out the specimen and do an end-to-end anastomosis, so that you can save the cost of the linear staple that altogether. But if it comes to the low anterior section, the techniques remains almost the same because there's no other options. But in the mid rectum, or if it is in the upper rectum, or even for sigmoid, you can very well do a hand-sewn anastomosis, avoiding all of the staples together. That is at all, but we use it very frequently, usually after third post-op day. In colonic resections also, we are not reluctant to use laxatives.
Sir, one more question. In inflamed bowel, will you avoid the mucosa?
Yes. It's better to take submucosa and try to approximate mucosa to mucosa together, but better not to include the mucosa because often it cuts through. Why I am saying is, so suppose you had to reoperate the patient, when you open up the anastomosis, you see that most often the mucosa becomes ischemic or black if you had taken full thickness. So inflamed or even otherwise, I think it's better not to avoid very bulky areas of mucosa.
Thank you, sir. That's an excellent point. Any more questions from the audience, please?
Thank you.
Thank you, sir. Thank you.
Thank you, sir. May I request you to kindly remain on the dais, sir? Prakash, sir. May I request the chairpersons to kindly do the honors and present him with the certificate. The special session lunch with the teachers will be at the terrace, which is adjacent to the hall. and lunch will be served at 1:30. We're moving on to the last speaker of this session, Dr. Sunil. May I invite Dr. Sunil, please? Dr. Sunil from Kottayam, please.
Thank you very much. Respected chairpersons and distinguished delegates and my dear students. I am a surprise speaker today. The speaker who was supposed to come had some illness and he couldn't make it today. So morning I was told to present, so the video is not mine. I have not prepared. So excuse me for any flaws. Thank you. Now, it's about submandibular thyroidectomy. The standard incision would be parallel to the lower border of the mandible. And important thing is to place 2 finger buds below the mandible so as you do not damage the marginal mandibular nerve. That's the first step. And subsequently, then you cut through the deep fascia. Do not dissect until you reach the deep fascia. There is a confusion as to some textbooks saying that the marginal mandibular nerve is superficial to deep fascia. That's why they say that you cut deep fascia and then dissect, then the chances are less. But then some of the anatomic textbooks say it is actually not superficial but deep. But either way, there is no advantage of dissecting superficial to deep fascia. The next thing that once you cut the deep fascia is to be careful about the facial artery. So the next step would be to deal with the facial artery, because facial artery, it has course very closely applied to the posterior and superior aspect of the submandibular nerve and submandibular gland, and therefore it's very likely to produce unwelcome hemorrhage. So the first thing would be to divide that. And then while you dissect, there are a slight difference when you do a benign submandibular versus a malignant. Whereas when you do a malignant, you don't go in the classical thing that you see here. You have to do a level 1 dissection, which means you have to remove the entire lymphatic structures, all the fibrofatty tissues in the level 1 area. It's not just the submandibular. But when it comes to the dissection of the submandibular, it's almost the same, because there are vital structures like the lingual nerve, the hypoglossal nerve, and then the facial artery, so which you really have to identify by being close. Now, when it comes to benign, it's always a good idea to go very close to the parenchyma of the gland, so that there is very little chance that you can damage any of these vital structures. Now, what you see there, I believe, is the ligation of the artery. And that's the digastric tendon that you're seeing. So the incision, I said 2 finger buds below, the posterior end of the incision would be to the level of the anterior border of the sternomastoid, and the anterior would be to the posterior border of the anterior belly of digastric. So that would place the incision correctly for reaching the submandibular gland. And then when it comes to the deeper dissection, as you all know, the superficial lobe and a deep lobe, a smaller deep lobe, which goes beneath the mylohyoid. So therefore, that's the area. Now, what's being ligated, I believe, is the upper part of the facial artery. So facial artery has to be ligated, artery and vein, has to be ligated below as well as above. There are surgeons who do not ligate the facial artery, and it can be saved, but then it would be much safer and easier if you ligate at both ends, so that there is less of a problem with the bleeding during surgery. And now I think this facial vein being ligated. And the thing about identifying the deep lobe is to identify the mylohyoid. Mylohyoid is the diaphragm of the floor or the floor of the mouth, So most of it, the superficial aspect of the gland is superficial to it. And then when you kind of retract it, then you will see the deep lobe. Now, hypoglossal nerve generally is not an issue because the gland is resting on the hyoglossus muscle. Hyoglossus is one of these flat extrinsic muscles of the tongue, and therefore this hypoglossal nerve actually goes beneath it, and therefore it doesn't come in this plane. But then if you just retract on this digastric tendon, you will be able to see the hypoglossal nerve, if at all you need to define it. And this bipolar is a good instrument, not just in submandibular, in most of the surgeries, including thyroid, where you do not damage, even if you go close to a nerve, you do not damage them, and there is no problem of bleeding. The other thing that you need to do is regarding lingual nerve and the submandibular ganglion. Now, these are found when you try to dissect on the deep lobe, and that too when it comes to the duct. Now, when it comes to the submandibular duct, the important thing is that if it is secondary to a stone disease, because that is one of the common indications of submandibular adenectomy, you need to palpate the stone if it is there, ideally preoperatively, and if it's actually within the oral cavity, it may be a good idea to incise and remove the stone. And there are situations when you do that, the entire problem might settle, at least for a long period, and you may be able to avoid surgery. Now, why? Because if the stone is quite anterior, it's very important that you do not ligate the duct posterior to and leave the stone there. It can lead to recurrent infections and trouble for the patient postoperatively. Now, what you see is the duct there, and when you pull down on the duct, you will see the lingual nerve coming down. So, lingual nerve actually comes from behind, loops down, and then the submandibular ganglion is hanging down from the lingual nerve. So, if you dissect close and then ligate the artery, after seeing this lingual nerve, there is no issue of lingual nerve as well. So, if you are careful, there is actually no much problem. The most important thing is that it's always good idea to drain. Now, we have always have the problem of whether to drain, not to drain. I've had one situation when one of my seniors had done surgery without drain. Post-operatively in the evening, there was some pain in the submandibular region. There is a dressing over it, so house surgeon came and gave an analgesic, and subsequently there was some breathlessness, gave Deriphyllin, and sometime later we found patient died. So this is because there was a hematoma there, it was not realized. So when you have the drain, the advantage is that there will be a clue, there will be blood in the drain. So it's always good idea, but if you're quite careful, if you use clips and you use bipolar efficiently, no problem. It is up to but then it is the responsibility of the surgeon. Then anything untoward occurs in the postoperative period, he be informed. Unlike, because quite often it is a very junior most person like a house surgeon who will be attending the calls. I have much more time. I have 6 minutes more, is it? Okay, now that's because, the video is not fine, and, I just keep saying, and it's not going, simultaneously with the video. So I think any doubts you can ask me, but not about this video, but about how do you do the procedure.
Very nice presentation, Dr. Singh, even though you have not prepared it. Very nice.
Thank you. I'm
Yeah.
grateful to Sajay Kumar. I was just asking him, Sajay Kumar and Raj, I was sitting in between both of them. I was asking them about some of these things, most of which I said right now is what they told me. Thank you.
Nowadays, the tendency is to avoid silentectomy. If you read the New Bailey, they say that Yeah,
Endoscopy.
Endoscopy.
Yeah.
Endoscopic removal of the stone. That's all. There is no need for a silentectomy.
I
Can
fully-
avoid silentectomy.
I fully agree with you, sir. Two problems are: one, we are talking to surgeons. Second,
Yeah.
I have not heard about this endoscope. I do not know whether this facility is available anywhere in Kerala. Can anyone tell me if you have access to silo endoscope?
So one option is to go for a cholecystoscope.
Yeah,
Any
yeah,
scope,
thank you,
any
thank-
scope, yeah.
Is it size? Does it fit in?
Some small pediatric cholecystoscopes are available.
It will go through.
In case of for a completion of removal of stones, after before cutting the ducts, you can check with the scope. This is one option, sir.
Oh, very good.
So any small scope will be enough. Anyway, we don't have to wait for a silentoscope.
We've been trying for the last 10 years to get a cholecystoscope, mainly for biliary surgery, CBD stones, and we've not been able to get one.
So retained stones after submandibular silentectomy is a real problem.
Yes.
Especially with the recurrent.
Yes. That's what, that point I was stressing too much, basically because it's a disaster.
Right.
Sir, what will be your advice for a young surgeons to avoid submandibular, marginal mandibular nerve injury?
Marginal mandibular, as I told you, the first thing is to place the incision at least 2 finger breadths below the lower border of the mandible, and then go up. Do not dissect. Keep cutting until you cut the platysma and the dysphagia, and you do not raise a plane before you reach that point. Number one. Number two is when you ligate the facial vein. The facial vein, that plane, it's the same as the mandibular nerve, the marginal mandibular, as per some of the textbooks. So if you retract that amount of tissue which contains this facial vein upwards, then it's very unlikely that you'll damage it.
So particularly the posterior facial vein.
Posterior facial. Actually, there is a confusion regarding posterior facial vein. Most of the anatomic textbooks do not mention that there is something called posterior facial vein. There is only facial vein, which is joined by the anterior division of the retromandibular vein. So it's that which some people call it as facial vein, posterior facial vein, because it's actually not draining the face. It is actually draining the retromandibular, which drains the inside, what it comes. So what is what you meant, I believe, is the anterior division of the retromandibular vein.
Right.
Thank you so much.
Sunil sir, Dr. Sunil, may I request you to kindly remain on the dais? We have a certificate handing out right now. Thank you very much, sir. Thank you to the esteemed chairpersons of the session. Thank you, sir.